Hi guys, welcome to the second video on the topic of diabetes mellitus. And if you come to this video directly, I would personally suggest you to listen to the part one of this video first, because that's where I've talked about the pathophysiology of the various types of diabetes, and then the first line interventions and some baseline principles which are to be followed. Now here I'll begin by describing a case-based scenario. I have a 8-year-old kid who's admitted with diagnosis of pneumonia. He has been admitted with me for the past 3 days, and today morning when I came for the round, the mother is telling me that the child has been having vomiting episodes since last night. He has been having severe epigastric pain and is appearing little drowsy, or maybe he's not opening his eyes, or even if he's opening his eyes, the mother is worried because the child looks as if he's not recognizing the mother, and all these events have occurred in the last 12 hours or so. The doctor on duty at night had given Perinom, instructed the nurse to give metoclopramide, but the vomiting part has not subsided. And when I looked at the vitals or the vitals chart, I noted that the heart rate was disproportionately high. Respiratory rate was fairly high. Respiratory rate I was anticipating because he's a case of pneumonia, so respiratory distress can be present. But the patient was currently afebrile, and I did notice pretty severe epigastric tenderness or rebound tenderness present. So initially, first thought process of mine was that this is a presentation of atypical pneumonia, because if a pneumonia patient is having GI complaints, it looks like atypical pneumonia only. But at the same time, because the epigastric tenderness was very pronounced, so I decided to think in terms of one, abdominal emergency, which could be in the form of acute pancreatitis or acute gastritis. And second, I was thinking it could be a metabolic problem as well. And meanwhile, I also instructed my nurse to get me access to a pulse oximeter so that we could at least quickly check the SpO2 of the child, which turned out to be fairly decent. Let me say it is 98% at room air at this moment, or even if the child was on supplemental oxygen because it's a case of pneumonia, the SpO2 was doing pretty decent. The plan is to now go in for urgent abdominal ultrasound bedside so that I can check out for any abdominal emergency. And to rule out any metabolic problem in the child, I am also ordering arterial blood gas analysis report. Lots of time the mother might be worried and she may not give me a permission to take the sample from the radial artery, though I'll take due diligence and I'll take good care that I'll be doing a modified Allen's test to check for the integrity of the radioulnar collaterals. But at the same time, the mother did not give a consent, so I got a VBG done. Anyway, my job would be satisfied because even a VBG will be giving a fairly accurate report. When I checked out the pH of this patient, I'm not worried about the PO2 part at this point of time because SpO2 is showing me a decent report, and the child is not in circulatory failure. So, I mean, normally in circulatory failure, the pulse oximeter report is not very reliable, but luckily the child is currently not in any kind of circulatory failure. So when I looked at the ABG report, then the pH of the patient was less. The partial pressure of carbon dioxide in this patient in the question can be given to be normal or can be lesser. I mean, traditionally speaking, in a respiratory issue, you see, if the person will do fast breathing, then it can explain the hyperventilation, can explain the low PCO to the patient. So it could be normal to a low value that could be given. But the main reason why pH is less will be evaluated or known to you when you look at the bicarbonate value. And in this case, pH is less and bicarbonate is also less. Considering the fact that there is a acidosis and bicarbonate is less, I know it is a metabolic acidosis, and therefore I've also decided and instructed my nurse to get a urine evaluation of this patient done for presence of ketones. When the report came, it was a shocking 4 plus or a 3 plus positivity, and I got a random blood sugar of the patient done as well, and that is turning out to be a shocking 300 milligram per deciliter. So you can see that I'm trying to work out a case where there is a metabolic acidosis, there are ketones, and there is a elevated sugar. If I add all the three things together, there is a acidosis, there are ketones present in the urine, and there is gonna be elevated blood sugar. It becomes a case of diabetic ketoacidosis. To be doubly sure that I am dealing with a case of diabetic ketoacidosis, I'll also order a plasma beta hydroxybutyrate values. And in fact, this test should be done to not only confirm that it is ketoacidosis, but this would also let you know regarding the severity of the disease. And the values were turning out to be super elevated. And therefore, on the basis of this, I can say that pneumonia is the trigger which is responsible for this presentation of the child, which can mimic abdominal emergency. Though more technical details of diabetic ketoacidosis is present even in a subsequent video, but I can say that the core aspect is what I've explained here, that pneumonia can be a trigger, or any intercurrent illness, it can be UTI for example, or any infection per se can be a triggering of development of diabetic ketoacidosis. And lots of time this diagnosis of diabetic ketoacidosis, you will come out in your practice, you will notice it will come out to be something like an accidental diagnosis, because initially I thought that the child is having these issues because of maybe abdominal emergency, but turned out to be a metabolic reason per se. So most of the time, if I had in this particular question, if I had already mentioned that he's a known case of diabetes mellitus and he did not take insulin for a few days, let me say the child was the family had gone for a marriage party, and the child did not know how to take insulin by himself. Mother was busy in some functions and the child missed a couple of dosages of insulin. That could be the starting point. And then he ate food at the wedding, and he became sick. He started having food poisoning, and because the child is not eating, the mother did not give anything to the child to eat. So anyway, diabetes is a condition of intracellular starvation, and if you don't eat, then the problem is that body will anyway need energy, so the body will burn fats to generate ketones, and that's how ketoacidosis can be triggered. I said two things: if it's a known case of type 1 diabetes mellitus, if insulin dosages are mixed, or there is an insulin pump malfunction in a patient, or there's a food poisoning due to which the food intake was restricted, and the insulin dosages were also mixed, the combination of that would trigger diabetic ketoacidosis. But in this case, I did not mention it like is a known case of diabetes. I tried to make it like an accidental diagnosis, and that is how it usually presents. And anyway, the cat would be out of the bag, or there would be no point of discussing this particular slide per se, had I begun by saying that the child is having small breathing, or had I said that the patient is having a fruity odor in the breath, because acetone will come in the breath. There are three ketone bodies, that is beta hydroxybutyrate, acetoacetate, and acetone. And acetoacetate breaks down to produce acetone, which is coming in the breath of the patient. That small breathing is because the ketones are acidic. So the acidic environment will stimulate the respiratory center, which explains the acidotic hyperventilation / small breathing in these patients. If these terms were mentioned, then anyway, right in the first few lines, it is ketoacidosis. So most MCQs will skip writing this data, but the data that I've currently mentioned in yellow will be given. Infection is usually a trigger for development of metabolic problem in this case. The clinical diagnosis of this case is DKA. As I've explained, investigation of choice for diabetes mellitus is HbA1c. But if he says, how are you sure that you're dealing with a case of diabetic ketoacidosis, then the blood work that you'll be doing would be plasma beta hydroxybutyrate values. If he says, what is the first line for management of this patient, it would be normal saline. And because the child has been vomiting, so there would be a depletion of total body potassium. So to take care of the depletion of total body potassium, potassium chloride can be given. The safe value potassium chloride that can be given concentration wise is 40 millimoles per liter. I mean, if we give concentration higher than this, then there can be cardiac conduction issues as well. As you know, hyperkalemia can contribute to even diastolic arrest in the heart. So I'll be obviously aggressive on potassium supplementation, but I'll not be super aggressive because I can cause cardiac conduction issues. If he says, what is the treatment of choice for this patient, we will be starting this chap subsequently on a insulin drip. This insulin drip is the main treatment because it will send sugar inside the muscles and the blood sugar will tend to stabilize. Once I give insulin, hypokalemia of this patient, which was already present, can actually worsen. So I did the wise thing by giving potassium chloride in advance only. Now, when I will give insulin drip, the sugar will start going inside the muscles and the blood sugar will begin to fall. Like suppose on diagnosis or on admission, the blood sugar was 300, when starts falling to 250, 200, or it can go to precipitously low values. So he mentions that if, or in a MCQ, if he says that what fluid should be given in the same patient when the blood sugar tends to go beyond or less than 250, then you will be changing the fluid to half normal saline, that is N/2 saline. And to this will be adding 5% dextrose. So when would you be adding 5% dextrose is when the blood sugar values will begin to reduce. If we do not intervene in this case, then the problem is there would be a development of cerebral edema. High sugar can cause fluid shifts across the brain. The large amount of protons in the system will also contribute to damage to the blood-brain barrier, encephalopathy. So cerebral edema is the leading cause of death, especially with respect to children. In adults, it can range from ARDS or it can be bowel infarction. and the usual trigger in most of the cases will turn out to be infection. Though if ketoacidosis is occurring in adults, then the trigger can be given. Yeah, I mean, ketoacidosis can be seen in type 2 diabetes also. So don't be under impression that it is seen only in type 1, can be seen in type 2 also. So that is why I'm writing that in adult patients, the trigger could be a stroke, it could be myocardial infarction, it could be a surgery that the patient has undergone, or it could be a urosepsis or urinary tract infection that could have been triggered by a kidney stone. So one, I would like you to be very thorough with respect to the presentation of diabetic ketoacidosis. More details of diabetic ketoacidosis are given in the subsequent video as well, but I just mentioned this so that you can handle the initial aspects, because anyway, since I have described type 1 diabetes pathophysiology in the previous video, so it had to come up that I had to describe diabetic ketoacidosis at this point of time. Now, once I will get this child out of ICU, the mother is asking me that, okay, sir, are you sure that my child is a diabetic? I told her, yeah, and I can do HB1C to be, further, allay her fear. I obviously know, because I know that symptoms with hyperglycemic crisis. In fact, that's an important aspect. I have said that even in video 1, that symptoms with random blood sugar can be sufficient for diagnosis of diabetes. Obviously, if you have a fasting blood sugar and a 2-hour plasma value, great. But even fasting blood sugar values, 2-hour values, which are like the gold standard way of diagnosing, or HbA1c, which is even much more accurate for diagnosis, even random blood sugar in presence of symptoms is sufficient for diagnosis. Now the mother is asking me, sir, what is the management algorithm that we'll be following in this case, or what will be the special precautions that I need to take? So one, I'll tell her that your child will be requiring insulin injections. So she's curious and she's saying, my child will require injections. Like, children are like scared of injections, right? And I told her that, yeah, we will train you, and gradually we'll train the child also, so that he can administer himself or herself with insulin injections. And she's looking at me with disbelief. She says, sir, you mean that my child will himself give himself an injection? Like, I would show her regarding this image. So she says, do you think seriously that a 10-year-old child can inject himself on the anterabdominal wall with the insulin syringe? So I'll tell her, yes, ma'am, we'll train you well, and we'll train your kid also, so that he can inject himself with insulin injection. She says, my child is terribly afraid of injections. So I'll tell her that the needles that we use are gonna be ultra fine. They're very thin. It would almost be a painless and a bloodless, because pain is the main reason the child is scared of. So gradually you will convince the mother as well as the child that this would be a very painless and a bloodless delivery of insulin. The first intervention that we need to do, however, is to take care of carbohydrate counting, which is that whatever is the carb that the child is eating, we need to basically revolve around insulin regimen around the amount of carbs that the child is eating. Like, for example, today at breakfast time, the child was given a aloo paratha by the mother, and he finds it very crispy, very nice. And he says to the mother that I want to eat a second one. Then you have to inform the mother, no, that because of the fact that the child is eating 2 aloo parathas instead of 1, because more carbohydrate load is going in the body, you will have to increase the dosage of insulin that has to be given to the patient. At the same time, suppose the child is, like, lots of times children are fussy eaters. So if a child is going to be eating lesser, then we'll have to reduce the dosage of insulin. But the point here is that, one, a mother should know that after how much time the insulin injection will start working, because we are giving the insulin shot before lunch, before dinner, and before breakfast. We'll be following a basal bolus regimen, but the mother should be knowing now that, okay, how much time before should I give? So like, we'll talk about rapid acting insulin, we'll talk about short acting insulin, and carbohydrate counting is the initial step, because the amount of insulin that you give in this case will be directly related to the amount of carbs being consumed. In type 2 diabetes mellitus, I'll be talking about caloric restriction. There I'll be talking about restrict the amount of carbohydrates to be given. But in a child, we are not doing any special restriction of carbohydrates. If a child is saying, I want to eat a paratha, I mean, we are okay with it. Whatever is the local cultural practices, we'll try to follow them, and we'll just try to revolve the amount of insulin that we give around the amount of carbohydrate that the child is consuming. Then physical activity is of paramount importance. The amount of physical activity that the child should be doing is about 60 minutes of activity per day. This would be about moderate to vigorous physical activity. Unlike in adults with type 2 diabetes mellitus, where we do not recommend vigorous physical activity, in a child, we would like him to do this vigorous physical activity. It will also tone his muscles, because after all, muscle wasting will also be present in type 1. So I want the child to develop some muscle strength as well. This would be about 60 minutes of moderate to vigorous physical activity on a daily basis. Whereas in type 2 diabetes, we avoid going for vigorous physical activity, because these patients could be having atherosclerotic plaques in their coronary arteries, and if that tears, they could even be a development of myocardial infarction. The main treatment for type 1 diabetes mellitus would be injections of insulin. And well, what will be the route of administration of insulin? So it will be subcutaneous. And what will be the site where the insulin will be injected? Then you can see from the figure itself that the site where we'll be giving insulin injections would be the anterior abdominal wall. You can imagine a circle of a radius about 2 centimeter. Like if I draw imaginary line here, then I can say that you can imagine a circle of a radius of about 2 centimeters. So we will not be giving injections immediately around the umbilicus, but we'll be giving it at a distance of about 2 centimeter from the umbilicus. And like this is the site where I'm preferring. So like if I'm using this site for Monday, then I can be using a different site for Tuesday, Wednesday, Thursday, and so on. So like I can go clockwise in this particular case, because I want to reduce the local trauma which is caused by the needle at a daily basis. If I use the same site using different needles obviously, but if I use the same site again and again on a daily basis, local trauma is anticipated, which is why I'm planning to change the site of administration, and I'll be using different needles every time I'm giving a insulin injection to the child. Obviously, the cost-wise perspective, it will be a little expensive for parents, but no, gradually the medical insurance sector in India is picking up, and even the deprived patients of type 1 diabetes mellitus can be getting the regular shots of insulin. So the preferred site is the anterabdominal wall. It is not immediately, I mean, it's not peri-umbilical. It is about 2 centimeter away from the umbilicus. And if the mother is not comfortable or the anterior abdominal wall is very thin, we can always use the anterolateral aspect of the thigh. We can use the anterolateral aspect or a little posterior. In fact, this that is shown is going in the arm, it's going a little towards the posterior side. So I would say anterolateral going towards posterior part of the arm is where I can be using the injection site. Or we can also use buttocks as well. I mean, buttocks will be having a lot of subcutaneous tissue. So even if in a Indian child, even if he belongs to low socioeconomic state of the society and is poor, still buttocks can be used. But on a comparative basis, if they ask you the preferred site of administration of insulin, then it would be the anterior abdominal wall, as you can see from this schematic. Now also he can ask you what is the method of delivery. So I've said two things at the moment. One is the route of administration and what is the preferred site. But he can also ask you regarding what is the preferred methodology of delivery of insulin to the patient. So the best answer would be an insulin pump. You see, this insulin pump is the game changer in a sense that we nowadays have CGM available. CGM would stand for continuous glucose monitoring, and this continuous glucose monitoring device, this will tell you obviously the real-time blood sugar of the patient, but this insulin pump will be able to adjust the delivery of insulin based on the actual blood sugar value of the patient. If suppose the parents are traveling and child has not eaten anything, child is a fussy eater, or he says I don't want to have dinner, we can cancel the delivery of insulin as well, manually as well. I mean, if the electronic device is not working, if maybe this readings are inaccurate, whatever the point is, even if the CGM device is not functioning properly due to whatever be the reason, that it has a particular life for which it will be able to do this reading. So suppose that lifespan is extended, then still we can manually operate the device and stop the delivery of insulin. So the best way of delivery of insulin is an insulin pump. You will have to, obviously, there's a cartridge which has to be purchased and loaded into the pump so that we can deliver the right amount of insulin proportional to the amount of blood sugar that is present in the body of this patient. And the alternative way for this insulin pump would be continuous subcutaneous insulin infusion. So the best method of delivery of insulin is CSII, that is continuous subcutaneous insulin infusion. And obviously, because this would be expensive and lots of time in low socioeconomic state of the society, people will not be able to afford it. So what they can use is an insulin pen. Now, as far as the insulin pen is concerned, the needle is ultra thin. It is 32G needle. We have 31G also. We have a 32G needle. The length of this needle can vary. I mean, you don't need to note down the length of the needle. It would be like starting from 4.5 millimeter, and then the length will go on. Like we have a 4.5 millimeter length needle, then we have 6.8, 12.7. So I mean, the length of this can keep on increasing dependent on the build and the requirement per se. But my point is that this needle will be very fine and thin. I mean, if you have given a BCG injection, BCG 26 gauge is a very thin needle, and this would be even more thinner than that. So the insulin pen with a 32G needle would be a very painless and a bloodless delivery of insulin. And if you have relatives abroad, then they'll be using this brand name of Afreeza. So we also have inhaled insulin available. I mean, in fact, it can be a question to you guys that inhaled insulin should be given how much time before the meal. So it should be given at least before 30 minutes. I mean, half an hour is the usual time in which the onset of action will be occurring. Whereas with rapid acting insulin, the action is usually about 25 minutes. So the mother has to be told, because see, mother, if she's a housewife or even if she's working, she'll have to juggle so many things. So she has to cook for kitchen, she has to fix tiffin of everybody, she has to take care of the household chores as well. So we'll tell her, ma'am, that if the shot of insulin is given, then the child should begin to eat within the next 25 minutes. So rapid acting insulin is usually given as a prandial dose. By prandial, I mean before the child eats, we'll give a shot of insulin. And we have inhaled insulin also available, which makes it little easier for the kids, in a sense that if a child doesn't want to take injections, absolutely no issues. Inhaled insulin would be a good way. Indian mother, however, may not be having access to all of this fancy stuff. So what most Indian people would be doing is, diabetics type 1 would be purchasing is a multi-dose vial of insulin, along with that standard 1 ml syringe. And then they'll be understanding the calibrations in the syringe from you, and they'll be doing a self-injection of insulin. As far as the storage temperature of this multi-dose vial of insulin is concerned, it should be stored in the door of the refrigerator. Now, lots of time in rural India, you may not be having access to a refrigerator. So if worst case scenario, you can keep it wrapped in a small towel which is soaked in water, and the evaporative losses from the water can basically ensure the stability of the molecule of insulin. See, India is a hot country. Even inside the house, if there is no air conditioning, the temperature would be 47, 48 degree or even higher in Rajasthan. So, I mean, how do you preserve the stability of insulin? Even if you have a fridge and the electricity is not there, still the insulin stability would be affected. So, therefore, we have to devise some ingenious methods, ranging from keeping it in a matka, that would be relatively cool, or a surahi, or like instead of going to those measures, I'm saying even if they wrap it in a wet towel and keep it in one corner in the house, the evaporative losses will ensure from the wet towel that at least it's kept relatively cool. So insulin pump, insulin pen, inhaled insulin, and multi-dose vials of insulin is the best way for delivery. And well, how do you give insulin to the patient? So we give a basal bolus. We use a basal bolus regimen. And what you mean by the basal bolus regimen is that every day at night time, the child will be receiving a long-acting insulin shot, that is glargine, which will be acting for the next 24 hours. So you can see that the red curve is actually extended a bit. I mean, it's coming from last night at 10 p.m. in the night when the child was going to bed. Long-acting insulin glargine was given, and the green representation is for that rapid-acting insulin like Lispro and Aspart, which will help in neutralizing the spike of sugar, because in diabetic patients usually the rise of sugar in the blood is very fast. I want the sugar to come back to euglycemic values. So to ensure the sugar comes back to this euglycemic values, I have given about 20 minutes before breakfast a shot of Lispro or Aspart. Same thing would happen with respect to lunch also, because the sugar will spike, because lunch is usually much more carbohydrate wise more dense. So the sugar will also rise much more faster. But then to bring it again back to euglycemic levels, I again need to give 25 minutes before the lunch time a shot of Lispro or Aspart. So one we are giving is a bolus shot. That bolus shot is basically implying the prandial part, that is right before the meals, about 20 minutes, 30 minutes before the meal. 20 to 30 minutes before the meal is the usual term that you will tell to parents. And the basal one is the long acting insulin. This basal is the bedtime insulin. This bedtime insulin is also called as peakless insulin. Peakless because you can see the dose response curve will not be having a standard bell-shaped curve, but the bedtime insulin that we use is the basal insulin, that will most of the time be glargine, and because the dose response curve of this is relatively flat, so we tend to call it peakless insulin as well. about 50% of whatever you will calculate based on body weight, 50% of that would be given as a basal insulin. The remaining 50% would be divided into 3 dosages and given to the child per se. And continuous glucose monitoring, as I've said, is a game changer because it gives you a real-time evidence and real-time values of how the sugar is behaving. So you can titrate the shots of insulin, you can titrate the amount of food that the person is consuming, you can regulate. Like if the child is doing too much of exercise without eating calories, again the blood sugar will begin to dip. Hypoglycemic episodes can occur. Or if the child is leading a sedentary lifestyle and is not doing exercise, and you are giving insulin shots to the patient and the sugar values are still spiking, so you will tell the mother to increase the physical activity of the child. So the main message is at least three aspects. What I want you to be clear are: what is the preferred route, what is the preferred site, and what is gonna be the preferred site of delivery. And the preferred site of delivery in this case is gonna be a insulin pump. Now, as far as the biggest side effect of insulin is concerned, it's gonna be hypoglycemia. So let's talk about when would we say hypoglycemia. In the exam, the cutoffs were given as 35, 45, 54, and 60. I repeat the options again: 35, 45, 54, and 60. And you will answer that the cutoff for hypoglycemia is less than 54 milligram per deciliter. Now, when do we say level 1 hypoglycemia? You see, insulin production in our body begins to stop when blood sugar becomes less than 70. So normal blood sugar is taken as 70 to 100. Why it is taken as 70 only and not as like 60? That's because 70 is the time when the insulin production begins to shut down and glucagon production begins to rise. So the lower limit of normoglycemia is taken to be 70. And if any blood sugar, if the blood sugar of a person is between the range of about 55 to 70 milligram, we will be saying that this would be level 1 hypoglycemia. But if it starts falling less than 54, then we'll say level 2 hypoglycemia. So that's just a quick classification that you need to remember. And for level 3 hypoglycemia, he does not give a mathematical value. He says any level which causes patient incapacitation. Like for example, a person was brought to you in an unconscious, semi-responsive or unresponsive state. So if my patient is having incapacitation, like person became drowsy or he went into a stupor, or the worst case scenario can be the person can land up into a hypoglycemic seizure and then would be brought into the hospital. So whatever is the value, and why here is saying any level is because see, some people are some people might be doing fasting from a very young age since they were children. So people who do regular fasting, they are more adept at handling low blood sugar values. And in some, by low I mean obviously the values would be going less than 54, but then there is no threshold that okay, only at value less than 40 will you be having a seizure, only value less than 35 will you be having seizure, or would you be going down to 20 and then you will be having a seizure. It depends. I mean, neuroglycopenia will obviously cause drowsiness, stupor, lethargy in a child, but then there is no well-defined level that okay, only below this much you will be having development of seizure. So it depends on the body capacity of everybody, and that is why is mentioned at any level. If there is incapacitation and person cannot perform on his own, he will need to be carried to the hospital. He is not able to independently do his daily chores or daily activities. That's where level 3 hypoglycemia would come in. What are the symptoms for hypoglycemia? Well, it begins as mood swings. Lots of time you would have seen that if you are gonna go for an exam without having your breakfast properly, then your attention span will begin to reduce. You will tend to feel more edgy. You will tend to feel more moody. You will tend to feel more irritable. And in fact, you tend to feel more angry also. So hypoglycemia causes person to become angry, moody, or excessively fretful. I can say fretful would mean that a person might be like shouting on other family members. And then you will start having palpitations and tremors. So features of sympathomimetic stimulation will start occurring in a person, and you will start having sweating also. Though the air conditioning will be working fine in the house, this person will be the only one wiping his sweat. So you have to explain to a diabetic that if you start having you have to tell the mother that if the child is behaving very cranky, and rota ja raha hai, right? So if the child is very cranky, or child is having excessive sweating, or adult person is having a lot of sweating, palpitation and tremors, it means that your blood sugar is beginning to fall. And at this point of time, you will tell them that carry something sweet with you, like a chocolate or a candy, or like anything sweet with you, so that if there is a hypoglycemic episode, you should be able to evaluate it, and you should be able to manage it effectively. Nowadays we have glucometers available, so with a prick we can evaluate whether person is hypoglycemic. If you have a CGM, then the chances of a person going into situation like this is unlikely, because continuous glucose monitoring, the dip of sugar can be seen on a digital display as well. But most of the time, because people may not be having access to it, so that's how the symptoms of hypoglycemia would come in. And what I'll say next is exclusively from pharmacological perspective, because you can see that sympathomimetic symptoms are the ones which are mainly being talked about. The sympathomimetic symptoms that we are mainly talking about are like palpitations in the form of tremors, in the form of rage attack, anger. Those are features that we usually associate with sympathomimetic drive. So therefore, in pharmacology, we will study that beta blockers are not recommended in diabetics. Why? Because if you are gonna be giving beta blockers, like especially a non-selective beta blocker like propranolol, then it will cut off beta 1, so palpitation will not be present, and tremors is via muscles, that is beta 2. So non-selective beta blocker will mask the symptoms of hypoglycemia. Now this is gonna be true basically from only the pharmacological perspective. In real clinical practice, lots of time you will notice that diabetics are on beta blockers. So I will give you justification for the same as well, but let us just cover the MCQ here. The message is that beta blockers tend to mask the symptoms of hypoglycemia. So the pharma book will say that they are usually not recommended, though that is not a real scenario. Then sometimes this question can be asked as except also. The question will say all of the following are gonna be symptoms seen with respect to hypoglycemia except. So when they say the word except, then that is the point when you would be giving the answer in the question as sweating, that is diaphoresis, because sweating would be having a cholinergic drive also present. So the main aspect is that this is true only from the perspective of pharmacology. This is not a reality. We regularly, you will be noticing that patients of type 2 diabetes mellitus who are having, let me say, triple vessel disease, double vessel disease, or are universally having coronary artery disease, which is contributing to chronic stable angina, they are on beta blockers. In fact, the drug of choice for management of chronic stable angina, you would have listened to the cardiology discussion. I have told that if a person is having like 70% or more blockages in the artery, then person will be developing chest pain on exercise. So that's where the beta blocker role comes in. So we do give beta blockers to diabetic patients who are having chronic stable angina or are having coronary artery disease. So it's only for the sake of an MCQ that I would like you to remember this information, that beta blockers mask the symptoms of hypoglycemia except the one by the name of diaphoresis. If it says, what is the treatment for management of hypoglycemia? I will be giving something sweet to the patient to eat, something like a candy or a chocolate. But suppose he gives me a scenario and he says that person is having hypoglycemic seizures. There is neurogleukopenia. The neurons are not getting sugar, and that's where the seizure begins to happen. Then I'll secure a IV line and give 25 to 50% dextrose to the patient. So the management of hypoglycemic seizures would be 25 to 50% dextrose. And then he can also change this MCQ by saying that IV access could not be obtained by the doctor. You see, if a person is having convulsions, like patient came diabetic, he had taken a shot of insulin, then became very drowsy, very lethargic, now is having convulsions right before your eyes. So you try to put a cannula got countered. Possible, no? If the patient is having violent shaking movements, cannula can get countered, no big deal. So doctor was not able to get a IV access, and he says, what would you do? And you tried a couple of times and still the IV line could not be secured, and you are not able to give IV dextrose to the patient. You obviously cannot put a NG tube in a chap who is having seizures. So because of risk of aspiration, and it's difficult to put when person is having convulsions in the very first place. So what I'm going to do in this case is ask my nurse to open the emergency tray and give me glucagon, that is the counter regulatory hormone of insulin. And yes, we have commercial preparation of glucagon available, which can be given as a subcutaneous injection to the patient, and that will tend to raise the blood sugar by causing glycogenolysis, because glucagon will break the glycogen in the liver and will cause the sugar to rise. So management of hypoglycemic seizures would be answered by you as 25 to 50% dextrose. If he mentions a child, then your answer would be given as 10% dextrose. So concentration wise, obviously you can adjust. But if he says you are not able to secure IV line, well, you would be giving glucagon to the patient. So hypoglycemia is one big side effect with respect to insulin, which is why you should be knowing regarding the type of insulin that you are giving and after how much time would it be acting in the body of the patient. Now, before we go forwards, I would also like to mention regarding what can be asked in the exam as a Somogai phenomenon. Let's say I have prescribed 10 units of glargine to be given at bedtime to my patient so that I can maintain a euglycemia of 150. I mean, that's a decent value to be achieved in a diabetic, 150. So I have advised 10 units of glargine to be given, and the blood sugar at the moment is 150 actually. So we are trying to optimize that the whole night the blood sugar remains constant. The problem in diabetic patients is that the blood sugar tends to show substantial spikes, and that spikes of sugar are the one where the fluid shifts across various organs can be causing damage. So I want a euglycemia. I don't want fluctuating sugar values. I have prescribed 10 units, but maybe because my handwriting was not good, or maybe the mother who was giving this insulin injection, she had some cataract issue. So my 0 can look like a 6, and therefore the child was given extra than what was prescribed amount of insulin. Well, you can understand that if a child or any patient is given extra insulin over and above whatever is recommended based on the body weight, then the blood sugar of the patient will begin to fall. And that is what I've tried to show here, that in this particular child, when he'll be sleeping, the blood sugar of the child will begin to dip. The reason for the dip in the blood sugar is that I have given more insulin. I mean, it could be one problem with my prescription. Second possibility is my prescription is fine, but the mother who was giving insulin gave more insulin because of either carelessness, or she herself has a refractive error, she herself maybe has a cataract, so her vision is impaired, and that is why she gave extra amount of insulin, and the blood sugar of the person will begin to fall. Now, if the blood sugar of a person will begin to fall, that is where the counter-regulatory hormones will start coming in. What are the counter-regulatory hormones? Glucagon, cortisol, catecholamine. So all the counter-regulatory hormones will now come in the picture, and the values of these will begin to rise, and therefore these counter-regulatory hormones which are being released at 4 a.m. in the morning will be responsible for the rebound of the sugar. That is, the sugar will not fall any further because the body is having a compensatory system working, and as a result of it, there is a possibility that when you are gonna check the fasting blood sugar of this patient in the morning, the blood sugar might be 200 or even higher than this. See, he is not having a value of 200 because he ate extra at night. He's not having a value of 200 because he took less amount of insulin at night. The value why it is elevated is primarily because of the fact that there was a release of counter-regulatory hormones. Now, this that I've currently explained to you, this 4 a.m. value in multiple choice questions will usually be written as early morning hypoglycemia. I know that you doctors study the whole night, and therefore even 7 a.m. will be looking like early morning for you. But nomenclature wise, that 4 a.m. value that we are going to take care of is called as early morning hypoglycemia. And what is the 7 a.m. value called as? This 7 a.m. value is what is called as pre-breakfast hyperglycemia. So you just need to get this terminology right. Somogai phenomenon has alphabet O coming up again and again, which tells you that there is a hypoglycemia occurring in this patient. I say that again, Somogai phenomenon is what? It is early morning hypoglycemia and a pre-breakfast hyperglycemia. That pre-breakfast hyperglycemia he will not ask you. He will mainly ask you regarding what is the initial presentation of Somogai phenomenon. It is early morning hypoglycemia, and the reason for this early morning hypoglycemia is this extra dose of insulin that was given either due to my faulty prescription or maybe because of wrong compliance on the part of the patient. In fact, you will understand or you will appreciate the importance of this Somogai phenomenon from what I say next in next 1 minute. That is for another phenomenon which is called as dawn phenomenon. So for dawn phenomenon, let me say the blood sugar of the patient at the time at bedtime is 150 milligram per deciliter, and the person was given 10 units of glargine as bedtime insulin by me, and the person has taken the correct dosage. So if we evaluate the blood sugar of this patient at even 4 a.m. in the morning, that is what I wanted, that the sugar value should remain almost constant. So it's turning out to be 150. So far so good. Now, the problem is that Dawn phenomenon is going to be encountered especially with respect to patients of type 2 diabetes mellitus. And what happens in these patients of type 2 diabetes mellitus is that we are having some receptors on the muscles which allow sugar to go inside the muscle. These special receptors that allow sugar to go in the muscle are called as GLUT4 receptors, and between 4 a.m. to 7 a.m. in the morning, this doesn't happen in you and me, but in patients of type 2 diabetes mellitus, between about 4 a.m. to 7 a.m., these receptors are literally on strike. And what I mean by strike is that there is a down regulation of these receptors. Because of the down regulation of these receptors, mark my words, that the receptors are on a strike between 4 a.m. to 7 a.m. Because they are not working, the sugar values in this patient will begin to rise. So no big deal that the 7 a.m. value of this person can also be 200 milligram per deciliter. I expected that the sugar value of this patient should remain constant, but it has shown a rise once again. Now, if we dissect the data, what is happening in this patient is at 4 a.m. obviously we are getting is a sugar that is pretty stable in this patient. But once again, when it comes to Dawn phenomenon, the common thing between both Somogai as well as Dawn phenomenon is that in Dawn phenomenon also there is a pre-breakfast hyperglycemia present in a patient. So because pre-breakfast hyperglycemia is present in both Dawn phenomenon as well as Somogai phenomenon, what is the differentiating feature between the two? The differentiating feature is that in Somogai there is a fall and then there is a rise, whereas here you can see sugar is either normal or it will be showing an upward trend. It can be normal or it will, like, it could be instead of 150 it could be 160, but what I'm trying to say is that it is showing a upward trend from this time onwards. I mean, since 4 a.m. the receptors are on a strike, they're not gonna work. In spite of the insulin being present, the receptors are gonna go on a strike, and this is what is seen with respect to type 2 diabetes mellitus. So both Dawn phenomenon and Somogai phenomenon, the common thing is pre-breakfast hyperglycemia, and he will ask you how would you differentiate between the two. The differentiation is on the basis of early morning hypoglycemia. Well, you don't need to wake up the patient at 4 a.m. for diagnosis of the same. What you need to just check out is the compliance on the part of the patient. You need to check out the dose of insulin that you are giving to this patient. And mainly for this early morning hypoglycemia due to extra insulin being given, that I wanted to speak about Somogai. Otherwise, my main objective was to focus on the topic of hypoglycemia, which is a big side effect with respect to insulin administration. Another condition which I would like to make a passing reference to at the moment, this is discussed in pancreatic neuroendocrine tumors in the endocrine section, but insulinoma also has hypoglycemia. So insulinoma is the most common functioning pituitary, it is the most common, like if the question says what is the most common functioning pituitary tumor, then for pituitary tumor your answer would be given as prolactinoma. But if I change this to what is overall the most common functioning pancreatic tumor, I mean that is the term that I wanted to just bring into your notice, then the most common functioning pancreatic tumor should be answered as insulinoma. Please remember the fact that if I change this to non-functioning tumor, then it is a PPoma. PPoma would mean a pancreatic polypeptide which has absolutely no biological effects present. So one, I mean, you have to anyway know about these datas, and then insulinoma will be having high level of insulin which will cause hypoglycemia. So we always read about Whipple's triad. Whipple's triad would be having three things: the blood sugar, I mean, there would be symptoms of hypoglycemia, the ones that I described of sympathomimetic stimulation with sweating. Apart from this, person will be having on documentation low blood sugar, and every time you give him something sweet to drink like fruity or anything sweet that he takes, the symptoms of hypoglycemia will totally disappear. So we read about Whipple's triad, that is symptoms of hypoglycemia, low blood sugar on workup, and resolution of symptoms on a sugar intake. We read about Whipple's disease, that is malabsorption, but Whipple's triad is with respect to insulinoma, and this happens to be the commonest functioning pancreatic tumor. So he will also ask you regarding the imaging modality of choice for this condition. The preferred imaging modality of choice for a insulinoma should be answered as gallium-68 dotatate PET CT scan. That is an update over the older data in the textbook. I mean, earlier you used to talk about endoscopic ultrasound, or used to talk about somatostatin scintigraphy. Currently, you will answer it as gallium-68 dotatate PET CT as the best imaging modality for both insulinoma and even in pheochromocytoma topic. Earlier, the scan that was used is MIBG scan, but now you will notice that this is gonna be answered as the imaging modality of choice in two tumors. both insulinoma as well as pheochromocytoma MCQ. This common data is to be remembered. This is an update from the current edition of the textbook as well. And once we have identified the tumor, he'll also ask you regarding what will be done for the diagnosis of insulinoma. That's again a very peculiar information, 72-hour prolonged fasting test. I mean, when you read this term, no, it is itself an enigma. 72-hour prolonged fasting insulin test and prolonged fasting test. And what we will do in this test would be that we'll be checking out the value of sugar in this patient, which will turn out to be low. But when you check out the RIA C-peptide level, when you check out the RIA insulin level, it will be ultra high, and both do not make sense because see, you should be having, when sugar is less, insulin production should stop. I mean, I said if blood sugar is less than 70, then the production of insulin should be stopping. And in this case, in spite of the fact that the sugar is low, it is in 50s, and still the tumor is producing C-peptide, the tumor is going to be producing insulin. So the bottom line is that this tumor will not respect physiology. And as far as the treatment of this condition is concerned, obviously surgical resection needs to be done, but he can ask you regarding a drug which will reduce the insulin production from the beta cells of pancreas. We study about this drug for management of hypertension. Diazoxide as a molecule would be useful for treatment of patients of insulinoma apart from octreotide. 4 points must know for this topic are Whipple's triad, a gallium-68 dotatate PET CT scan, 72-hour prolonged fasting test, and diazoxide is the drug of choice for management of this condition, though obviously the surgical treatment would be a surgical resection of the tumor contributing to hypoglycemia. Why I spoke about insulinoma at the moment is just to remind you the fact that insulinoma will also contribute to hypoglycemia. But I mean, the difference would mainly be based on the fact that in these patients, the C-peptide values and the insulin values would be grossly elevated. And the most important point is that hypoglycemia traditionally will not be having an elevated insulin level. Insulin production should start to shut down when the values go less than 70. So this is totally opposite of physiology, which is why I have spoken about it. Next, we'll focus on the properties of various insulin preparations. In the current edition of Harrison, is divided them into long-acting and short-acting insulin, though traditionally we have been reading about them as rapid-acting, intermediate-acting, regular insulin, long-acting insulin, ultra-long-acting insulin. So, well, which is the ultra-long-acting insulin? That's going to be degludec. Degludec overall is the longest acting insulin with the action going up to as long as 42 hours. Whereas if he says what is the duration of action of detamir and glargine, well, these would be acting for about 24 hours. So just need to invert the numbers 24 and 42 respectively. And then detamir, glargine, degludec, they're also referred to as peakless insulin. Well, why we call them peakless insulin is mainly because traditionally whenever we give insulin, there would be a dose response curve that would be created, that would be bell shaped. Like if I talk about NPH, NPH is neutral protamine higdon. Then the short of NPH traditionally is what is referred as intermediate acting insulin. If a short of neutral protamine higdon is given, it will start acting after 2 hours. The peak values will be obtained by 4 to 10 hours, and then it will fall by 10 to 16. So once again you can see, because peak is being produced, the dose response curve will be in the form of a bell. But when it comes to detamir and glargine, like they would be preferred at bedtime. So if I suppose symbolically this represents bedtime insulin, the value dose response curve would look like this before you give the next shot again at 10 p.m. in the night. So overall, as such, I can say ultra long acting, just using English there, ultra long acting is degludec. Long acting molecules are going to be detamir and glargine. And as far as NPH is concerned, you will say intermediate acting insulin. This is pure usage of English only. In the current edition of Harrison, he has mentioned regarding only long acting and short acting, but then detamir and glargine would be written as long acting using English. And if I say degludec, that would be ultra long acting insulin. So that's just pure application of English only, but you need to know regarding when do they start acting, when the peak effect of NPH is gonna come, that is about 4 to 10 hours, and then the total duration of each one of these. As far as short acting are concerned, especially with respect to aspart, glulicin and lispro, these injections will start working within 25 minutes. So I mean, if the shot is given of lispro or aspart, 1 unit of lispro or aspart can neutralize about 15 grams of carbohydrate. So whatever is the aloo parantha that is being consumed by a patient, because we nowadays have apps available that will exactly tell you that okay, one parantha will use how much of atta. Along with that, obviously there would be some stuffing of potato also, then there would be some oil also poured. So we can work out the total amount of calories that are going to go in the body of the patient, and the carbs that are going in the body of this patient, and how much insulin would then be required. Like I said, 1 unit can neutralize approximately about 15 grams of carbohydrate. So these lispro, aspart, and glutathione, in the older editions of the books, they were referred as rapid acting insulin. As far as regular insulin is concerned, the advantage is it can be given intravenously as well. I mean, all other forms of insulin are given as subcutaneous injection, but regular insulin which starts working within half an hour to 1 hour, and the upper limit is about 4 to 8 hours. This would be referred to as short acting insulin. So we have a rapid acting insulin, we have a short acting insulin available. Rapid acting would be working within 25 minutes. Regular acting insulin will start working after 30 minutes, but if you give it intravenously, then it will start acting immediately only, no? So specifically, when would you be using the regular variety of insulin? Special indication where regular insulin would be used would be one for management of diabetic ketoacidosis, and second, IV regular insulin would be given for life-threatening hyperkalemia as well. So when you read about that insulin drip in DKA, when you read about that insulin drip for hyperkalemia, that is where we shall be using the regular variety of insulin. And then we have Freeza, the inhaled insulin, which will start working in 30 minutes, as I've explained earlier, and will be acting for about 3 hours or so. So from the pharmacology perspective, you need to remember the onset and the duration. I mean, you'll have to put some time in remembering the numbers which are present here. But over and above this, what I can say is that as far as insulin preparations are concerned, we have combinations also available. The combinations would be like of NPH with the rapid acting insulin. So the advantage of that would be that you'll get benefit of both. Like aspart will start acting immediately. So when you eat food, the sugar will spike. That immediate spike will be controlled by using aspart. But if in the same injection NPH is also present, then because NPH will be acting for good 10 hours, so you'll be able to flatten the curve. Like in COVID, we were saying flatten the curve of the disease. Here I'm saying that when you give insulin to the patient, you will be able to flatten the curve of the rise of blood sugar. Like you are given a shot of insulin, the blood sugar is spiking, so now the curve will become much more flattened. Otherwise, the spike will continue. So our objective is to obtain euglycemia in the patient, and let us now practice regarding what are the indications for usage of insulin. The first indication for giving insulin, and has been discussed earlier also, is like in type 2 diabetes mellitus, if at diagnosis itself the HbA1c values are more than 10%, and the random blood sugar of the patient or random plasma glucose of the patient is in excess of 250 milligram, then it is time that we straight away introduce insulin injections in the patient instead of oral hypoglycemic drugs. Though if a person doesn't agree or consent to it, then we can give oral hypoglycemic drugs also. The second scenario where we'll be using insulin is if there is a documentation of catabolism, if there's a prominent weight loss in a person, then it's recommended to give insulin. Insulin will help in weight gain of the person as well. If there is documentation of any ketosis or ketoacidosis, again, usage of insulin, the regular variety is required. 4, 5, 6 that I say are very general, so they're unlikely to be asked in the exam. You are aware that in gestational diabetes mellitus, we can be using insulin in the patient. Similarly, if a person is having organ damage, like the person is having diabetic nephropathy, and his GFR is substantially reduced, then we will have to give insulin. Well, insulin is also excreted by the kidneys only. Like you can't use metformin. Like let's say metformin is contraindicated if the estimated GFR of the patient is less than 30. So in case a person of diabetic nephropathy is continue to give metformin if the eGFR is less than 30 ml per minute, then he can land up in lactic acidosis as well. So it would be gross medical negligence on my part. I'll stop metformin in the patient, and what I'll be doing is giving insulin. And because insulin is also excreted by the kidney, so we'll be giving about 80% of the total dosage. So organ damage, in any scenario, we'll be giving insulin. If it is peri-operative, like he's a diabetic, he's undergone a surgery, then I'm going to keep him nil per orally, and I'm not going to allow him to take any medicines as well. So on the day of the surgery and post-operatively, it would be more logical that we use insulin injections in the patient. Apart from this, another indication would be HbA1c of the patient is more than 9%, in spite of usage of multiple oral hypoglycemic drugs. So we are giving total of 3 oral hypoglycemic agents that are being used in the patient. Like we are using metformin, GLP-1 RA, agonist, or we are also using DPP4 inhibitor, or we can combine GLP-1 with multiple categories. So if 3 or more oral hypoglycemic agents are being used and still we are having elevated blood sugar, we can be using insulin. Apart from this, I've also explained that if a person is diagnosed to be having LADA, latent autoimmune diabetes, in adults, and the C-peptide levels progressively fall. Initially, the patient might be put on metformin and diagnosed as type 2 diabetes mellitus, but as the C-peptide values will fall to less than 0.3 millimoles per liter, that would imply that we will have to switch him over to insulin. And in this list, I've not included emergency indications. I mean, the emergency indications for insulin are what I mentioned on the previous slide. I mean, these are the emergency scenarios where insulin will be used: diabetic ketoacidosis and hyperkalemia. But overall, I can say, in fact, ketosis is present in this list also. But the point is, these are like overall, I can say, are indications for usage of insulin. Next, let's look at the glycemic targets that we want to achieve in a patient. So the fasting plasma glucose of the patient should be between 80 to 130 milligram per deciliter. The postprandial values should be less than 180. This is first time that I'm using the word postprandial, because postprandial, as I told you, is not useful for diagnosis of diabetes, but for monitoring and checking out whether the blood sugar compliance is being made by a patient. So the glycemic target after food should be kept as less than 180. What is good sugar control? Good sugar control is HbA1c less than 7%. But I'll not be very strict in achieving a HbA1c of 7% in an elderly, frail patient, especially if he mentions a person is having osteoporosis or person is having osteoarthritis of the knees. Then I will not be very strict in enforcing a HbA1c of 7%. A value around 8% is fairly decent. Then is a new concept in the ADA 2023, that is time in range. Time in range means that the blood sugar should remain in the limit between 70 to 180 milligram per deciliter for at least 70% of the total time in the day. The basic concept is in 24 hours, 70% of the time the sugar should remain in this particular range. Just to explain this time in range, what I can say is, suppose we have a patient in whom the blood sugar fluctuation usually is seen between 150 to 200. There's a second patient in whom the fluctuation is between 100 to 300. I mean, higher is the fluctuation of blood sugar, more is the possibility of complications in a patient. So he says that we want to maintain a range. The range safe is between 70 to 180 for more than 70% of the time. But if it's going to be a relatively older patient, high risk patient who cannot do exercise, even dietary compliances might be difficult in these patients. So then if I can achieve this value of about 70 to 180 for at least 50% of the time as well, then I am like okay, achieving good glycemic control. So the point is, HbA1c is for long-term control, but we are breaking up the target into daily basis. That was 70% of the time in the day your sugar value should remain in this range. And how do you achieve this? That is a combination of diet control plus exercise plus insulin in type 1 and obviously oral hypoglycemic agents in type 2 diabetes mellitus. In gestational diabetes mellitus, you don't need to remember the value. That's usually given to be between 63 to 140. And here the rules are little more strict, that we would like to achieve this for more than 90% of the time. So gestational diabetes mellitus, I can say, is like not very important, but just try to remember that in type 1 and type 2 diabetes, for 70% of the total time in the day, the values should remain between 70 to 180. That's a target of like, okay, achieving a decent blood sugar control, so that all the bad things that we have discussed, all the bad complications that we have discussed can be minimized. Next up is management of type 2 diabetes mellitus, and the first step would be diet control, which is referred as medical nutritional therapy. In fact, the efficacy of this can be gauged from the fact that the fall of HbA1c with strict diet control can be up to the range of about 1 to 3 percentage points. In fact, one of the most efficacious drugs that we introduced first line, metformin, causes approximately about 2 percentage point fall in the value of HbA1c if taken regularly over 3 to 6 months. But in contrast, when you look at medical nutritional therapy, that is diet control, you can achieve a astounding 3 percentage point fall in the value of HbA1c over the next 3 to 6 months in a patient. So though diet control is difficult to achieve, you see, if you eat less amount of calories on a particular day, then the next day you will continue to have calories and you'll end up snacking. And because of that, ultimately you will tend to eat more amount of calories than what was actually recommended for us. So it's very difficult to achieve a hypocaloric diet, but with proper guidance under your care and under a care of a dietitian, it is possible to ensure a regular hypocaloric diet to be consumed by a patient. And one of the important weapons that we'll be using for hypocaloric diet would be carbohydrate restriction. And when I'm advising carbohydrate restriction, I will also be telling the patient to go easy on roti and rice, because most of the time chapati and rice is the staple food in India. So what I'll be recommending for this guy is that, okay, you want to have chapati, fine, I mean, it's okay, lunch you can have a chapati, but at night I would suggest you to use multigrain atta, or instead of using white rice, you can be using a brown rice, or you can be using millets for your breakfast. So what I'm trying to do is gradually change the daily intake pattern of this patient to those cereals which are having relatively a low glycemic index. Like for example, oat based diet can be recommended, or multigrain atta can be recommended. If he's a non-vegetarian and he wants to eat mutton, we'll tell him that red meat tends to increase the incidence of heart disease, but chicken is okay. And at the same time, I mean, turkey, like from Western population, is perfectly fine. If he wants to have eggs, that's okay. Egg white is fine, but not the yellow component, which has to be discarded. What we will tell him very categorically is that you eat whatever you feel like, but at the same time, zero intake is recommended with respect to trans fats. You are aware that the most dangerous dietary fat that we eat is trans fat. So whether we are taking aloo tikki from a local restaurant, or we are eating a aloo tikki burger from McDonald's or KFC fried chicken, that's going to be loaded with trans fats. So it's zero trans fats. It is zero intake of cola. It is zero intake of like Sprite or Coke, etc. So simple sugars are a big no. Intake of fructose, which could be present in couple of syrup solutions or juices, etc., is a big no for the patient. So we have to be a little subtle while we gradually introduce dietary changes, and the dietary changes should be culturally appropriate as well. And with a combination of exercise program that will lay down for the patient and a hypocaloric diet, he will be in a position to lose weight. If you lose weight about 5 to 10%, you will be reducing cardiovascular mortality in the patient as well. As far as exercise or physical activity is concerned, how does physical activity work? Because the patient will ask you, sir, should I be joining a gym? Should I take a gold membership, platinum membership? So I'll tell him, no need of a gym. You just purchase some walking shoes and you do brisk walking. And he's saying, how will it help me? I mean, brisk walking to the level, it makes you slightly breathless, but not, I mean, I don't want him to do vigorous workout. Vigorous workout would not be recommended in these patients. And well, how would GLUT4 receptors on the muscle, upgrade of these receptors on the muscle by brisk walking help? Because this GLUT4 helps in entry of sugar in the muscle. So if you promote sugar entry into the muscle, well, the problem is solved, because ultimately in diabetes mellitus, sugar is more in the blood. It's not going inside in either a setting of absolute insulin deficiency or relative insulin deficiency due to insulin resistance. So if we can promote sugar entry into the muscle, it will help in a good glycemic control. So what is recommended for our patient? I mean, what kind of activity would be recommended? It would be brisk walking, it could be light aerobics, it can be resistance training. Obviously, in older patients, I would not be recommending aerobics or resistance training. Then there is more important is balance control, and I don't want the person to fall. And how many minutes of activity? There are so many apps available. So about 150 minutes of light aerobic activity per week is sufficient. The person should be exercising for at least 3 times per week, like Monday, Tuesday, Wednesday. We can give 1 day off for the muscles of this person. I mean, 2 days of consecutive inactivity is what is not recommended. This is in contrast to type 1 diabetes, where I was telling you that the amount of physical activity would be about 60 minutes of moderate to vigorous activity. Just a repetition, in type 1 diabetes mellitus, 60 minutes of daily activity is recommended. This would be going from moderate to up to vigorous activity. So like the child can be running after a football, he could be playing basketball, or like Wasim Akram, I can mention. Wasim Akram was a Pakistani fast bowler, and he used to take insulin injections on a regular basis to keep his blood sugar under check, and used to do vigorous physical activity. And he had suffered from diabetes mellitus from a very young age, so probably would have been LADA most of the time. But anyway, I mean, I'm not aware of the medical records of Wasim Akram. What I'm trying to say is that to be a fast bowler, you need a lot of strength in the shoulder, you need a lot of physical stamina to take insulin injections, go out to play, and then you need to regulate your blood sugar as well. So if Wasim Akram can do it, then ordinary people who are not doing too much of strenuous activity can definitely manage with mild to moderate amount of activity activity, and if you increase physical activity, you burn more sugar, and that helps in achieving glycemic control. So these two steps are of paramount importance for management of patients of type 2 diabetes mellitus. And then comes the role of oral hypoglycemic agents. I've already sensitized you to the fact that if at diagnosis itself the HbA1c of the patient is more than 10%, or if this report is not available and at diagnosis itself the fasting plasma glucose is usually in excess of 250, then we will recommend to start straight away on insulin, and we can add metformin as a backup subsequently. But in a MCQ as well as in practice, if he mentions regarding type 2 diabetes and HbA1c is equal to or greater than 10%, then first answer is not metformin, it would be answered as insulin. Now let us look at how bigonides, that is metformin, will be working. This is one of the most commonly prescribed drugs, and it does not cause hypoglycemia. Hypoglycemia is mainly seen with sulfonylureas. As far as metformin is concerned, there are two main mechanisms of action. The first mechanism of action is it inhibits hepatic gluconeogenesis, because our liver will keep on producing sugar on a regular basis from various substances. So the hepatic gluconeogenesis part, the brakes would be put. And second, what metformin is going to do is it's going to enhance or increase peripheral glucose utilization. What I mean by the word enhancing peripheral glucose utilization is utilization of sugar by the muscles and the adipose tissue. In fact, if metformin is taken in maximum dosages for about 3 to 6 months on a regular basis, we can anticipate a fall of HbA1c up to 2%. It varies from patient to patient, but up to 2% fall of metformin can be seen in patients with regular intake. And obviously, all these things go in sync. I mean, medical nutritional therapy is not isolated diet control. It goes in combination with exercise. And if we are adding oral hypoglycemic drugs or we are adding insulin, then that would be supplementary and will help in better glycemic control. So metformin per se can cause a 2 percentage point fall in the value of HbA1c, whatever is present at diagnosis. As far as the side effects of metformin are concerned, most of the time he'll ask you regarding B12 deficiency or lactic acidosis. The B12 deficiency would be fairly common in vegetarian patients. The maximum dose of metformin that can be taken is about 2 grams. That's important because the message is that metformin is excreted via the kidney. So because of the fact that if kidney is damaged in a diabetic and you still continue to give metformin, that would constitute medical negligence. The good things about metformin are 2 percentage point fall in HbA1c with the max dose being taken. And at the same time, this is going to reduce both the micro as well as the macrovascular complications of diabetes that I explained to you in the earlier part. That microvascular would be like neuropathy, nephropathy, retinopathy. Macrovascular would be complications like coronary artery disease and peripheral arterial disease. So these are going to be the good things which we will be encountering. But as I said, because this molecule is excreted via the kidney, this molecule is absolutely contraindicated if the estimated GFR of a patient is less than 30 ml per minute. And there have been instances when very famous doctors have continued giving metformin to patients. Maybe it would be not actually, I would say, total lack of oversight on the part of a doctor. Patient will play a role in that he did not come for regular follow-ups. And when he did, the doctor was engrossed in multiple other things. So he missed up the fact that the kidney has been damaged. So don't give metformin if VAGFR is less than 30 ml per minute. And the reason for that being that if you continue giving metformin in a setting where eGFR is going to be less than 30 ml per minute, then a big side effect can come, that is in the form of development of lactic acidosis type B. So this is a point to watch out from the MCQ perspective. In the older versions of the app, I used to say metformin is not to be given as serum creatinine is more than 1.5 milligram, but now instead of saying creatinine, he's talking in the values of estimated GFR per se. As far as the side effects of metformin are concerned, it's going to be standard nausea, vomiting, metallic taste in the mouth. So till this point, it is still tolerable, or you can convince the patient. But then other features that can be asked to you can be B12 deficiency, more pronounced in in vegetarian patients. And not to forget the side effect of lactic acidosis. As I explained, this would only be seen if the estimated GFR is low. But there is a cousin of this molecule, fenformin, that was withdrawn from the market primarily because it used to cause lactic acidosis even with a normal kidney function. So do remember, fenformin is anyway banned since early 1990s, but you'll still read the name of that in your pharmacology books. And when should you be stopping metformin? Then one is obviously a teenage kidney function test, but over and above this, you need to remember that if your patient with diabetes, suppose he has been advised by the physician to undergo a coronary angiography because he was having features suggestive of chronic stable angina, then radiographic contrast study whenever needs to be done, metformin in the patient should be stopped. Similarly, if the person is being hospitalized for any reason, whether he's gonna be hospitalized for, let me say, gallbladder surgery, or maybe he's having piles, any situation where the person is going to be hospitalized and we're going to put him nil per orally, then metformin in the person should be discontinued. Over and above this, any patient having metabolic acidosis, if there is a liver failure developing, if there is the presence of congestive heart failure which is going into a decompensation, that is ADCHF, which will anyway mean that the person has become hospitalized. So these are a couple of situations we need to stop metformin in the patient. Though I mean, the where I have written stop metformin at the moment, 1 2 3 4 5 would still be temporary, in a sense that once the person will come out of these problems, like angiography has been done and he is being sent back home, then we can continue with metformin. If he comes out of decompensated congestive heart failure, we can continue with metformin subsequently, but on a permanent basis where it would be stopped would be what I highlighted in a separate color, estimated GFR values less than 30. Now we'll talk about the second drug which should be introduced now, that is GLP-1RA, and that is glucagon-like peptide 1 receptor agonist. And these are again insulin secretagogues, and they all of them, I mean all of the names of these molecules will be ending with glutide, like exenatide, liraglutide, or lixisenatide, or semaglutide. In fact, semaglutide is the one which is a rage nowadays due to the reasons that I'll explain to you. So how these molecules will work is because they're insulin secretagogues, so they'll upgrade the value of insulin. And in type 2 diabetes mellitus, we also have a problem not only with the receptors of insulin, but even the alpha cells of the pancreas are malfunctioning, that they tend to output more glucagon. So you see, in diabetic patients, you will always notice that blood sugar is elevated, and in spite of being elevated blood sugar, glucagon is still being released. Traditionally, if the blood sugar value tends to rise, no, glucagon production should go down, because the function of glucagon is rise of sugar. If the sugar is showing an increasing trend, then glucagon's alpha cells should regulate and should sense that rise of sugar, and they should decrease the production of glucagon, but that does not happen in type 2 diabetes. So these drugs will be also causing a reduction in the glucagon value. Plus, they slow the gastric emptying. The advantage of that is going to be a postprandial rise of sugar. The postprandial excursion is going to be lesser. It will induce early satiety, which is why these drugs I was saying are a rage nowadays, because they can be causing a weight loss. So especially in type 2 diabetes mellitus, especially American patients who are obese, who eat too much of fat, too much of cheese, if they are having substantial obesity, then semaglutide will do the job for them. Why I talked about these drugs right in the beginning of the topic of diabetes mellitus is because they stabilize the atherosclerotic plaque. So they're going to cause a substantial reduction in cardiovascular mortality per se because of the stabilization of the atherosclerotic plaque. The drugs available are exenatide, liraglutide, then lixisenatide. As far as semaglutide is concerned, it is available as once a week. I mean, earlier the question used to come simply as like, which of the following is once a week injection for management of patients of type 2 diabetes mellitus, and we used to answer liraglutide or semaglutide. And semaglutide is currently available as oral tablets as well. Then there's a FDA black box warning that you would be aware from pharmacology that this drug has been shown in rats to cause an increase in thyroid C cell tumors, because of which this molecule is contraindicated, especially in patients who are having medullary, if they are having a family history of medullary carcinoma thyroid, or in patients who are having multiple endocrine neoplasia. The topic of men has been discussed separately, but you will be remembering that medullary thyroid cancer or medullary carcinoma thyroid would be coming in men 2A or men 2, that is Sippel syndrome. So we will not be prescribing GLP in those patients where multiple endocrine neoplasia is present in the case, or there's a positive family history of multiple endocrine neoplasias. But otherwise, I mean, like every cloud has a silver lining. You are having a lot of good things about this molecule. It is reducing, most importantly is like it is reducing the alpha cell malfunction, because that's always a neglected part of diabetes mellitus. We're always talking about beta cell, we're talking about beta cell receptor, or we're talking about insulin receptor, but alpha cells are like malfunctioning. So this molecule is like, you know, taking the bull by the horns, that it is controlling those alpha cells. It is also reducing weight of an individual, that will reduce the CV mortality, and obviously stabilizing atherosclerotic plaques, which makes them a very favorable drug. Though the fall of HbA1c with these molecules category will be up to 1% only, but it is a supplementary complementary benefit that we are getting, that we are getting a control of blood sugar, but at the same time, the reduction of CV mortality is one of the primary reasons why these drugs are being studied. And then we'll talk about DPP-4 inhibitors, which will inhibit the degradation of native GLP-1. Glucagon-like peptide, where is it produced from? Like when whatever we eat, no, then our intestine, our ileum, normally we study about ileum, terminal ileum for B12 absorption, but in our ileum, we have special cells which are called as L cells. And there are a couple of them, L cells, K cells, and these L cells produce GLP-1, and this GLP-1 behaves like insulin, and it tends to basically send sugar inside the muscles. However, this GLP-1 is destroyed by enzyme by the name of DPP-4, that is dipeptidyl peptidase 4. So if I will put brakes on the breakdown, this molecule, what it is doing is that it is causing a inhibition of the breakdown of GLP-1, which is produced by the L cells of our ileum. And because of that, because this molecule will now be able to act for longer duration, so it will send more sugar inside the cells. If it will send more sugar inside the cells, it is for benefit for me. So I mean, it is saying it is promoting insulin secretion, that is okay. But then the main point is this molecule which is promoting insulin secretion is degraded by enzyme. If you block the enzyme which breaks it, then the total duration of action for which this molecule will be able to promote insulin secretion will be relatively longer. And the drugs available are like sitagliptin, saxagliptin, linagliptin. Linagliptin is the one which is metabolized by the liver, whereas the first two are metabolized by the kidney. So this is itself a question that which DPP-4 inhibitor can be given safely in patients with kidney failure. Then the DPP-4 inhibitor that can be given safely in patients with kidney failure would be linagliptin. In fact, from the pharmacology perspective, the drugs which are going to be safe from the perspective of liver failure in a patient would be like this. One is sulfonylurea by the name of glipizide. In fact, alphabet L is coming up there also. So I'll just write it down. Glipizide is metabolized by the liver. And then another one that is metabolized by the liver is linagliptin. So both of these molecules are relatively, because they're metabolized by the liver, so they are going to be safe in those patients in whom the kidney is compromised. Then is the traditional drugs. I mean, in the older edition, we used to talk first about sulfonylureas. And in this edition, I've talked about GLP-1 receptor agonist, primarily because that's how it is described in the book, that because diabetics would be having concomitant atherosclerotic cardiovascular disease, therefore GLP-1 receptor agonist would be recommended. And the molecules that we're talking about at the moment are like glipizide, glyburide, all of them will be beginning with G. And how do they act? They act on ATP sensitive potassium channels, and they promote insulin release. In beta cells, well, type 2 diabetes, in late phases, there is a beta cell exhaustion. Beta cells are frustrated and insulin values will decrease. But in the early phase of type 2 diabetes mellitus, we are having still some reserve of insulin present, which can be forced to be released from the beta cells by the usage of these drugs. So that is why it is saying that when will you be using insulin secretagogues, molecules like glipizide, gliclazide, glimepiride, that is when it's type 2 diabetes of recent origin, when there is some residual insulin production still present. In after 20 years, like suppose diabetes was starting at 40 and at 70, the beta cells are totally exhausted, then these drugs will not be working. The biggest side effect of insulin secretagogues is development of hypoglycemia. And second, because they are promoting release of insulin, weight gain will also be happening. As far as metformin is concerned, if he says what is the status, answer it as a weight neutral drug. Guys, please do not answer metformin as a weight reducing drug. It is to be answered as a weight neutral drug per se. In contrast, sulfonylureas will be causing a weight gain because they are causing an increase in the any drug, that will cause an increase in insulin levels. Even the therapeutic insulin that you're giving will contribute to development of weight gain in a person. Then there's another category called as meglinitide. The molecules are like rapaglanide, netaglanide. I mean, they're not sulfonylureas, but they will still be acting on the same ATP sensitive potassium channels. So they're referred as secretagogues. They're not same as sulfonylureas, but still they do the same function in a sense that they do, though they belong to a different category, but they ultimately act via acting on the ATP sensitive potassium channels, and therefore values of insulin will be rising. Then comes thioazolidons, on which a large amount of questions can be coming. Thioazolidons, how do they act? They decrease insulin resistance, receptor resistance, by activating or binding to the peroxisomal proliferator activated receptor PPAR gamma. But then lots of times the side effects related to these drugs are the ones which are usually asked. So like I was teaching you that which drug will be causing a reduction in CV mortality like semaglutide. Now I'm saying the opposite, which drug which be contraindicated in a diabetic with heart failure, then answer would be thioazolidone. So molecules like pioglitazone and rosiglitazone are not recommended in patients with heart failure. So this is to be remembered: drug causing worsening of CV mortality, drug causing improvement in CV mortality. And when I say worsening of CV mortality, it means that if it is prescribed to a heart failure patient, the incidence, or I can say the severity of heart failure, will tend to worsen. Then there are reports with respect to it causing worsening of macular edema, therefore visual loss can be present. In PCOD patients, however, a very surprising finding is seen. They tend to induce ovulation, so the risk of pregnancy, I mean, patient doesn't want a pregnancy, unwanted pregnancy can happen. Though PCOD patients would be happy with this so-called side effect, but then at the same time, if a person of PCOD just wants treatment for cosmetic aspects, like the lady is having hirsutism, so she says, I just want my hormones to be normal, I want only my hirsutism part to be taken care of, and I don't want to have a baby. So if she's on thiazolidones, then that caution has to be exercised. Then postmenopausal women, fracture risk is increased, and with pioglitazone there is a FDA warning with respect to increased risk of bladder cancer. Usually two drugs where we read about risk of bladder cancer are pioglitazone and second is dapagliflozin. Dapagliflozin would be a SGLT2 inhibitor, but these are MCQs. I mean, say like lot of MCQs in the from pharmacological perspective with respect to side effect of thiazolidones can be asked to you. The drugs that I'm talking about here are like pioglitazone, rosiglitazone. Because I just mentioned the category, so I thought I should just mention the name in this particular case. And the only, I would say, silver lining in the cloud, like the cloud, why I'm saying is because it's like dark and it's causing so many issues. But then the silver lining in that cloud is what? That pioglitazone, rosiglitazone have been shown to reduce. They are used in secondary prevention of stroke. They are not going to be useful for primary prevention of stroke. They are useful for preventing, like see here what I've written, stroke recurrence. So that's like a advantage that we have with this, that in a, especially if you will listen to me in the neurology section where I've talked about transient ischemic attack, that is where I mentioned that if a person has suffered from stroke and is also diabetic, then what anti-diabetic drug can I start in that guy apart from the standard drugs which will reduce the recurrence of stroke? That is gonna be pioglitazone. So that's why like it was a silver lining in the cloud, I mean, an advantage. Otherwise everything on the slide was a disadvantage. Let's now talk about the second most commonly studied drugs after GLP-1 receptor agonist as of nowadays. I mean, present on prescription of every physician, every conference you are talking about SGLT2 inhibitors. So let's look at how are they working. Well, you are aware that there is a transporter in the proximal converted tubule by the name of SGLT2, and that is sodium glucose linked transporter, and we are putting a break because this SGLT2 will be promoting gain of both salt as well as sugar. So if I'm gonna be inhibiting this transporter, then the good news is that sugar will not be absorbed and the sugar will be lost in the urine. And if I'm gonna be promoting sugar loss from the body, then it is beneficial, because in a diabetic sugar is anyway high in the body. So if I promote loss of sugar from the body, it's gonna be beneficial for me. And I mean, in a diabetic, I want to get rid of sugar somehow or the other. So the good news is that the mechanism of action of this drug is that it will be helping in promotion, or it will promote sugar loss in the urine. The disadvantage of this can be that there can be a theoretical risk of increased incidence of UTI. That can be negated by increasing the amount of water intake, but still that should be remembered, and that is given in the textbook also, that side effect of SGLT2 inhibitors can be in the form of urinary tract infections or risk of mycotic infections as well. That's because of the higher concentration of sugar in the urine. The advantages of this drug now are like outstanding, that they will reduce the progression of CKD. But there is again a rider and a clause. Do not prescribe SGLT2 inhibitor if the eGFR of the patient is less than 45. So if you're listening to me carefully, when I was describing regarding metformin, the lower limit that I described was 30. But with respect to SGLT2 inhibitors, it's a range between 30 to 45, but then less than 45 it says don't prescribe them. The beauty of this drug is that it is causing loss of sugar in the urine, that is okay, but it is also losing salt, right? And that is going to be advantages for me, because if I lose salt from the body, it will reduce the expansion of the plasma volume. It will help me in control of blood pressure. And that is a huge, huge advantage. I mean, up to a 5 millimeter fall of blood pressure can be seen. And that is why it reduces CV mortality. So SGLT2 inhibitors have a dual advantage. They have cardio-renal advantage. I'll say that again. SGLT2 inhibitors have a cardio-renal advantage. What I mean by cardio advantage is, if I'm losing salt from the body, the BP is decreasing. That's going to be better for the heart. The stress on the heart will be lesser. The workload of the heart will be lesser. And what I mean by cardio-renal improvement is, it also reduces the progression of damage in the kidney. So traditionally, we have been using ACE inhibitors to decline or arrest the decline of the kidney function in a diabetic. But now we have an additional drug available in the form of SGLT2 inhibitors. So the drugs that are recommended are empagliflozin or canagliflozin. In a multiple choice question, if he says which drugs reduce CV mortality, there are two of them, GLP-1 receptor agonist and SGLT2 inhibitors. Both are going to be causing a substantial improvement in the CV mortality of a patient. Though pharmacology was dapagliflozin can increase bladder cancer risk, and there's a theoretical risk of increase of UTI also, which can be negated by increased water intake. So, I mean, GLP-1 receptor agonist and SGLT2 inhibitors, please read them up from pharmacology as well. And after you've done those two categories, the next category to be studied is thioazolidons for all the bad things that we have discussed in this particular case, ranging from not being advised in patients with hepatic failure or congestive heart failure, or they can worsen CV mortality in a person, or like a diabetic was advised a CABG by you. He did not undergo a CABG, so he will develop ischemic cardiomyopathy. Ischemic cardiomyopathy will cause heart failure, and because if he goes into heart failure, then thioazolidons are not to be given. But the advantage I said was, if he suffers from a stroke, then to prevent a second episode of stroke, rosiglitazone has been shown to be advantageous. As far as alpha glucosidase inhibitors are concerned, the main mechanism of action of these molecules will be that they will be mainly taken with meal. Like, why are we studying about acarbose or voglibose or migletol? Is because of the fact that these two medicines that I'm describing to you at the moment, they will be taken with meal. All anti-diabetic medicines need to be taken before a meal, but which anti-diabetic medicine is taken with meals is the one that we are discussing at the moment. I repeat that again. If a person is a diabetic, I mean, I'll tell him no, sulfonylurea or whichever medicine is to be taken, metformin has to be taken before a meal. But medicine which is taken with the meal implies that I'll ask him to keep the medicine on the dining table. And when he starts eating food, with the first bite of food, he's also taking this tablet, because the main mechanism of action of this drug is that it will inhibit the GI absorption of sugar. I mean, what is the mechanism of action? Inhibit the GI absorption of sugar. And the good news is, if sugar will not be absorbed, the PP excretion, the postprandial rise will not happen. But the bad news is, if the sugar will not be absorbed, it will dry in water also, no? And that will cause an osmotic diarrhea. So the dose limiting side effect of alpha glucosidase inhibitors is diarrhea. I mean, most patients, when they come for a follow-up, no, they will be saying, sir, this medicine is causing loose motions in me. Please stop it, or please adjust the dose. And you might have to actually stop this medicine because of the osmotic diarrhea. That's a dose limiting side effect of this molecule. Otherwise, I can say from mechanism of action perspective, very attractive action. No, I mean, if a drug is going to be inhibiting absorption of sugar from the gut, patient is going to be very happy listening to this. He said, now I can eat a chocolate, I can eat a rasgulla, or I can eat like a gulab jamun, because if I eat at gulab jamun and I take a carbos, then sugar will not be absorbed. So I'll tell him, no, don't do that, because obviously sugar absorption will be hampered and your PP spike will not happen. But you are going to have to go to the bathroom multiple times, because osmotic diarrhea would be coming in. So they are like supportive drugs. They're adjunctive drugs that can be added for glycemic control. The fall of HbA1c with alpha glucosidase inhibitor is only 0.25%. When an educated person will hear that 0.25% fall of HbA1c, sir, I mean, why are you writing this for me? So I'll tell him that this is not for long-term control. This design we have deliberately designed not for a long-term control, but mainly to control the postprandial spike that is occurring in this person. And what I've tried to do here before you is explain the various drugs that are used in management of type 1 and type 2 diabetes mellitus. As far as biguanides are concerned, I've already explained the main mechanism of action would be inhibition. That's a quick revision. Next, let me say 2 minutes. Inhibition of hepatic gluconeogenesis. And the second mechanism of action of this molecule will be increase in the peripheral utilization of the sugar. And if I do both of these actions, well, what's going to happen? It's going to cause a fall in HbA1c. The magnitude of fall of HbA1c is up to 2%, so highly effective. Alpha glucoside inhibitors would be causing a range about it's a range. I mean, usually I said most of the time it's about 0.25%. The upper limit, if the compliance is there, can go up to 0.8, but it's very difficult to achieve. The mechanism of action of this molecule will be inhibiting the GI absorption of sugar. So most of the time I can say that the metformin compliance is excellent. Patients might come to you with that metallic taste and nausea, vomiting. That's with every medicine, and that can be, you can convince a patient. But loose motions are something that's like a patient would be difficult to convince. So the upper limit with good would be in a range of about 0.5 to 0.8. But you check out in the table, no values would be relatively, I mean, on the lower side for alpha glucosidase inhibitors. Then as far as sitagliptin or vildagliptin, saxagliptin are concerned, the main mechanism of these would be inhibiting the degradation of GLP-1. And the good thing is that GLP-1, which is endogenously produced by our cells in the ileum, it behaves like insulin. So you are basically inhibiting the breakdown of insulin, and that's why it was written increase insulin action. So the bottom line is you will still be able to get a good glycemic control. Sulfonylureas, there are two categories, sulfonylureas and non-sulfonylureas, but both of these molecules will be acting on those ATP sensitive potassium channels. And by acting on these ATP sensitive potassium channels per se, they will be promoting a release of insulin, and therefore weight gain will be a common feature that will be seen with them, and even hypoglycemic episodes would be fairly common with both of these categories and are relatively more common with the superior category. In fact, when I describe like this, the query of most people is that, sir, I mean, if both of these molecules are gonna be acting on the same channel, then why? I mean, understandable. One is a insulin secretagogue sulfonylurea category, other one is non-sulfonylurea category. But then what's the fundamental difference between the two? The fundamental difference is that the superior drugs which begin with G are relatively longer acting. And as far as the inferior molecules are concerned, they're relatively short acting. So you can therefore see also, because they're relatively shorter acting, therefore the fall of HbA1c is max of 1%, whereas with sulfonylurea category, because they're relatively longer acting, the fall can go up to 2 percentage points. So in a multiple choice question from the pharmacology perspective, which drugs are causing a substantial HbA1c fall, then there are two answers. Metformin causes a 2 percentage point, and then insulin secretagogues, that is metformin along with sulfonylureas, they are one of the commonly prescribed drugs in India. You see, GLP-1 receptor agonist has come now, but otherwise if you talk to most diabetics, like in a government hospital, the commonest prescription would be metformin, the glipizide, or like any molecule that is beginning with G per se. Then comes SGLT2 inhibitors. So how are they working? They are basically working by promoting the sugar loss in the urine of a patient. And the good news is, if you promote sugar loss, then the blood sugar will tend to come down. And apart from that, the benefit of CV mortality anyway is there. Thioazolidons, as I've explained, that is PPAR gamma. That's the activation or the binding of this molecule with, and thereby they act by reducing. I mean, the advantage of this PPAR gamma activation would be decrease in insulin resistance. As far as GLP-1 receptor agonists are concerned, they will again, they have a very superior action. In fact, so many actions. They are insulin secretagogues, they decrease the glucagon production, they decrease stomach motility, they cause early satiety, they stabilize atherosclerotic plaques. So multiple aspects that I mentioned. And one of the main reasons why I've gone into this slide is to sensitize you and remind you for a data from pharmacology that which drug can be used both in type 1 as well as type 2 diabetes mellitus. Then pramlintide is a molecule which can be used in both type 1 and type 2 diabetes mellitus, and this molecule acts by regulating stomach motility. The molecule acts by regulating stomach motility. As far as insulin is concerned, I've already talked about it, and I've already explained to you. For medical nutritional therapy, look at the value. Up to 3 percentage point reduction in the value of HbA1c can be done. So especially for this particular table, guys, I would like you to take a snapshot of it and try to write down the mechanism of action of each of these drugs by yourself, and try to remember the side effects of these as well. I mean, this is a summary from the medicine and pharmacological perspective. I mean, you need to add one more, I can say, column to the table, in a sense that the side effects of each of these drugs should be known. But try doing it, guys, in a single page. note down the data for all oral hypoglycemic agents, check out their efficacy, check out their side effects and MOA. I mean, that's standard bread and butter data that you should be knowing. And why I've deliberately, I could have said, I've already discussed that. So this could be printed also, and I could have just underlined it, but I did the hard work of writing and just focusing on the data once again, so that I can just emphasize the importance of this data from the exam perspective before you. Then in diabetics, there is always a problem with respect to hyperlipidemia. So for primary prevention, we will have to give statins. Now, when you give statins, what should be the target? If person is having no cardiovascular risk factor, in a sense that he is not having any, his father did not have any premature coronary artery disease, he is not a smoker, there are no cardiovascular risk factors as of now, then the target LDL in this patient who's a diabetic by himself would be kept as 100 milligram. But if there is one cardiovascular risk factor, like this guy is a smoker also, then in those circumstances, the target that I want to achieve with high intensity statin would be less than 70. So all I'm saying is that I'm talking about risky, high risk patient, very high risk and extremely high risk. I'm saying high risk, very high risk and extremely high risk. What I mean by extremely high risk is person has already had a MI. If he begins the question by saying that a diabetic patient had already suffered from myocardial infarction, and now what is the target LDL in this extremely high risk patient, then your answer would be given as less than 55. In fact, in this slide, what you need to remember is mainly the data that I mentioned. See, for ordinary people like you and me, 130 is what is the LDL value. For a diabetic, the target is less than 100. For a diabetic with additional cardiovascular risk factors in the form of, let me say, smoking or premature coronary artery disease, or his lipid profile is grossly deranged with HDL being extremely low, triglycerides being high, LDL being super high, then I'll try to achieve a target of less than 70. But most of the time we will say diabetic has already suffered from a MI. He was treated by, in myocardial infarction, we had either done a PCI or we had gone in for thrombolysis, and the person is out of the intensive care unit. Then in those circumstances, we'll be using high intensity statin, that is atorvastatin, up to 80 milligrams per day, and the target is 55. The three values I'll say again: high risk, very high risk and extremely high risk. Extremely high risk is the data that you need to remember, value less than 55, because remaining 170 is what I know that you'll still be able to answer. Diabetes is not about only controlling sugar. It is about controlling sugar plus taking care of the cardiovascular health of the patient, plus taking care of the kidney health of a patient, because that is what we have seen, that earlier we were focusing only on sugar control and we were neglecting other aspects, and that is why, in spite of our medical care, these patients were expiring. If the person's triglyceride is, suppose LDL is normal and only triglyceride is super elevated, more than 500, that is when fenofibrate will be used. If LDL and triglyceride both are elevated, then we will use statin only. Suppose he gives a question and he has done that in the previous year. If LDL triglycerides both are elevated and he says what is to be started in a diabetic who's having a cardiovascular mortality, enhanced atherosclerotic cardiovascular disease mortality, I'll give statin. But if it is predominant triglyceridemia due to the risk of pancreatitis, I'll be using fenofibrate. Then a very underlooked data, and this came up especially in 2023, that they did a study in Delhi and they found that almost 33% of Delhiites are suffering from fatty liver. And most of them are either diabetic or some of them are non-diabetic as well. But obesity is anyway increasing in our country. People are gorging on momos and Domino's pizza and cheese burst pizza. So we should anyway be knowing regarding non-alcoholic fatty liver disease. Definition of fatty infiltration of when you say fatty liver is when more than 5% of the hepatocytes are affected. But if you're having a combination of fatty liver with ballooning of hepatocytes, there is damage to hepatocytes, there is no fibrosis, then we will say that this is non-alcoholic steatotic hepatitis. See, the word is steatosis plus hepatitis. So hepatitis means that there is ballooning of hepatocytes, there is damage to hepatocytes. Steatosis means there is a fatty infiltration of the liver cells, plus there is evidence of hepatitis. So we say steatotic hepatitis, and currently, diabetes is one of the important reasons along with obesity or metabolic syndrome for cause or development of non-alcoholic steatotic hepatitis. Well, how do you know non-alcoholic steatotic hepatitis without an ultrasound, without an elastography? We have a FIB-4 score. The four components of the FIB score are MCQs by themselves, and I would suggest you to listen to the liver discussion as well, especially when I've talked about liver cirrhosis. Prior to that, I've talked about this. FIB score will be having 4 parameters: age, SGOT, SGPT is understandable, they're liver parameters, but look at what you need to remember, that is platelet count. So age is understandable. I mean, any score can be including age of a patient, but then age, liver enzymes, SGOT, SGPT, and platelet count is in fifth score. And the main test that we'll be doing is elastography or fibroscan. I mean, the units in which elastography, I mean, more than how much kilopascals will you be saying fatty liver is discussed with respect to the liver section, but then fatty liver is again a neglected part. So as I said earlier, I mean, don't focus only on controlling sugar. You have to control the lipids in a patient. You need to take care of the fatty liver component as well. As of now, there is no FDA approved drug treatment for non-alcoholic steatotic hepatitis. So the main thing that we'll be advising, even in this case, would be diet control and weight loss. I mean, they are the one main approaches. Diet approaches and weight loss is the primary way to manage this patient, though I mean we are some studies do mention about the role of pioglitazone. So weight loss and diet approaches are the ones. There is no FDA approval according to the 21st edition of Harrison, though there are a couple of clinical studies in which pioglitazone has been used with decent results with non-alcoholic fatty liver per se. Then as far as long-term complications in diabetes are concerned, this is a quick revision of your ophthalmology. The earliest fundus finding in a diabetic patient would be development of microaneurysms. In hypertensive retinopathy, we will be having focal attenuation of arterioles. Hypertension will cause spasm, so focal attenuation. And in diabetes D for dilatation, that is microaneurysm formation, is the earliest fundus finding in a diabetic retinopathy patient. Then he will ask you also, like, there are 10 layers in the retina. So he will ask you that this microaneurysm formation will be occurring in which layer? Like the options in the exam were inner nuclear layer, outer nuclear layer, inner plexiform, outer plexiform. So I would suggest you to read the 10 layers of the retina so that you can get an orientation. And microaneurysm formation is mainly located in the inner nuclear layer. Then a diabetic patient can develop a non-proliferative retinopathy that is in the form of macular edema. This macular edema is one of the main reasons for development of a visual loss. Mark my words there, I did not say blindness. Blindness is what I will say next with respect to proliferative retinopathy. Because in proliferative retinopathy, I'm going to be having neovascularization, and this new blood vessels will put a load on the retina, and therefore retinal detachment can occur. Even if retinal detachment cannot occur, you could still be having a damage to these vessels, and the end result would be vitreous hemorrhage. Vitreous is transparent. The opacity due to the bleed will contribute to blindness developing in this patient. As I've explained, diabetic patients can go blind, and the incidence of blindness in diabetic population can be up to 25 times higher, astoundingly high value. The chances of blindness in a diabetic can be substantially higher than non-diabetic population. Now, because I know that due to these two factors, there can be blindness. Therefore, I need to go into what can we do to prevent this from happening. While doing questions, please be careful. If he says visual loss, it's macular edema. If he talks about blindness, it's neovascularization. There is going to be vitreous hemorrhage. There's going to be retinal detachment that will be occurring, and that will contribute to the blindness in this patient. So these are like a quick repetition from the ophthalmological perspective for you guys. How much time will it take in type 1 diabetes to cause a retinopathy? Then it will take 5 years of poor sugar control. And in type 2 diabetes mellitus, it will take about 20 years for the damage to occur. And you will notice that diabetic retinopathy and nephropathy progress with the same speed. You see, diabetic retinopathy and diabetic nephropathy progression is with the same speed. I mean, in type 1 it will take 5 years, in type 2 it will take about 15 to 20 years. So the progression of damage is the same. The learning point is, if eyes are involved, scan the kidneys, and if the kidneys are involved, scan the eyes of the patient. The speed of progression of damage in both of them is identical. As far as the data of 5 years is for type 1 and 15 to 20, I'll write the data on a subsequent slide. In this particular slide, the test that I can describe before you, which can tell me that person is having retinopathy. Obviously, I can do a fundus examination, but the test that can tell me that the person is having a diabetic retinopathy is one, serum creatinine, because if the kidney will be damaged, serum creatinine will begin to rise. Or instead of serum creatinine, I can calculate the estimated GFR of a patient. And if the eGFR of the patient becomes to progressively reduce for months altogether, that again tells me that he's going into CKD. So if he's having CKD, then eyes are getting involved in the patient. Now, lots of times serum creatinine will take a long time to get elevated. So he might also ask you, if in the MCQ you are getting simple, like diabetic retinopathy is occurring in a patient, what blood test can be done? We can be doing serum creatinine in the patient. But on the other hand, if he gives you both creatinine and homocysteine, then the problem with creatinine is it will take a longer time to rise. So serum homocysteine levels can also be checked, and they have been found to correlate with early identification of the retinopathy component. See, the best way for diagnosis of retinopathy is obviously a fundus examination, but these AIMS people and NSAID people, they always try to ask you things out of the box. So the question was, diabetic retinopathy can be identified by which blood test? I mean, looks surprising, right? Retinopathy will be a fundus examination. So the blood tests are two of them. And obviously, like, no textbook is saying that these tests are to be done in isolation. He says serum homocysteine and serum creatinine derangement both help in giving credibility to the fact. But it's a very myopic view on an MCQ when you are asked to select one in NSAID, because multiple correct options can be there. Then I can say both 1 and 2 in tandem work as a tag team to tell you that, okay, I mean, the kidney is involved, so the eyes are also getting involved in a patient. In a multiple choice question, we are forced to select between one. It's slightly controversial, but then 1 versus 2, I would suggest you to first answer a serum so homocysteine level. So that's a bit of controversial data because that is not substantiated in any textbook. It's mainly in journals, but probably they put up a question from there. Now coming to the treatment part of retinopathy, what we'll do is, this is what you study in ophthal, that we'll be taking care of this neovascularization, or we'll be destroying these blood vessels by using a laser beam. So we'll be going in for a pan-retinal photocoagulation using ND-YAG laser, and we'll destroy these abnormal vessels because blindness is to be prevented. And along with this pan-retinal photocoagulation, we will also be using injections, intravitreal injections of VEGF, that is bevacizumab. This bevacizumab would be a anti-vascular endothelial growth factor injections which would be given intravitreal. And well, the advantage of these molecules, this molecule is that though you have destroyed the abnormal blood vessels, but new one can still crop up, no? I mean, if I'm saying I'll be using the heat of the laser beam to destroy the abnormal vessel, okay. But what about the ones that can develop subsequently? So intravitreal injections of bevacizumab have been shown to prevent the development of new blood vessels. So diabetic retinopathy, do read it up from ophthal as well, tends to progress with the same speed as a nephropathy, the damage in the kidney. And I'll just explain the nephropathy features in a while as well, because after all, the leading cause of kidney transplantation in India and America is diabetic nephropathy, or end-stage renal disease necessitating a kidney transplantation is nephropathy. And if transplantation is not available, we might have to go for dialysis as well. Then we can have diabetic neuropathy as well. In diabetic neuropathy, the question will usually say, which of the following system is for, I mean, nerves are mixed, no? Nerves would be having sensory component, nerves would be having a motor component. So your answer would be, first we have a sensory involvement, then we have a motor involvement, and then we have is a autonomic involvement. Now, as far as the motor involvement is concerned, the usual question will say, which is the most common cranial nerve involved in diabetic neuropathy? Then you need to remember it's going to be third nerve palsy with, please remember that word, third nerve palsy with pupillary sparing. So the light reflex in the patient is going to be preserved. I mean, third nerve palsy will cause levator palpebrae superioris getting affected, medial rectus getting affected. So ptosis can come, diplopia can come, but pupillary sparing will ensure that the light reflex in the patient is okay. From the autonomic involvement perspective, he can ask you regarding one, postural hypotension or orthostatic hypotension. The definition of postural hypotension has been asked in the exam, so we'll be doing a tilt table test for it. Lots of time in India, we may not be having a tilt table where we can secure the patient and then tilt the patient up to 70% head elevation. So most of the time, what we are going to do in a government setup with limited resources is first check the BP in supine position, then check the BP in standing position. And we'll not check the BP immediately on standing or in a tilt table test. When we do a head end elevation, we're not gonna check the BP of the patient immediately. What we are gonna do is that we're gonna wait for 3 minutes, let the compensatory mechanisms work. And if we find that the systolic blood pressure is falling more than 20 and the diastolic blood pressure is falling more than 10 millimeter of mercury, then we call it postural hypotension. See, all the time I've been talking about increased blood pressure, so I just wanted to grab this opportunity to talk about definition of postural hypotension, which is fall of systolic blood pressure more than 20, diastolic more than 10 on change of position from supine to standing. He can also ask you regarding what drug, because this would be having substantial amount of disability. So the drug that we can be using for management of postural hypotension is midodrine. usually two MCQs where we read about middle drain. One is hepatorenal syndrome. I'll not get into hepatorenal syndrome at the moment, that changed the focus. But then we read about midodrine, one for management of postural hypotension, and second we read about midodrine with respect to hepatorenal syndrome, HRS basically, which has been discussed in the liver section per se. Other autonomic involvement can be in the form of constipation or diarrhea, so we'll have to use drugs for management of the same. So constipation, diarrhea, I don't think that they'll contribute to any, I mean, they're obviously causing a disability, but they'll not contribute to a potential head injury or death in a patient. But orthostatic hypotension, like this diabetic stands up and suddenly his hand starts spinning and he falls down, that can be a potential cause of both severe morbidity as well as mortality. The earliest to be involved is obviously the sensory component, and he will ask you that what is usually going to happen. So it's going to be answered by you as distal sensory loss. Apart from distal sensory loss component, he can ask you regarding which nerves are involved here. So in diabetes, we do not have damage to the large and thick fibers. Like in physiology, you read about A beta, A gamma, or A delta fibers. So here it is mainly the unmyelinated C fibers which are getting involved. That means it is the small nerve fibers which are getting involved, and they are the ones which would be carrying pain as well. So lots of time patients of diabetes might be complaining of pain or discomfort in the soles of the feet. I think if you are having a diabetic relative, the usual complaint that you will tell, he or she will tell you is that I'm not able to sleep at night because of pain or discomfort which is felt by them in the soles. And this would be having impairment of nighttime sleep. It would be discomfort or burning sensation or pain or allodynia that would be described by the patient in the soles. So for management of this discomfort or the pain that is present, you will have to use drugs, and the drugs that you can be using are in the form of either duloxetine, or you can be using gabapentin for these patients, pregabalin, carbamazepine. These are the drugs which carbamazepine is what you read for even trigeminal neuralgia. So, and even in sciatica, you might be using these drugs. So in diabetic neuropathy, most of the time it's gonna talk about sensory issues in a person. And because I said there is going to be a distal sensory loss, so what you also need to understand is that if a diabetic is walking bare feet and he gets injured, then because you and me, if we get injured in the sole of the foot, it's gonna hurt, no? But a diabetic, because if it's not gonna hurt, he might continue going about his daily activity. He might be wearing chappals and he's having an injury in the foot, and that injury in the foot can get infected as well. So no big deal that you could be having a development of a neuropathic ulcer in the sole of the foot. It would be a non-healing ulcer. The reason for the non-healing is manifold. That, one, the blood vessels in diabetes are also affected. So you have angiopathy. So the wounds do not heal on time. Diabetic patients, you would have seen, they take a extremely long time when it comes to healing of wounds. But the direct implication of this direct distal sensory loss can be development of a neuropathic ulcer. And though we read about the topic of ulcer in surgery, but if they give you an image of a ulcer in the sole of the foot, most of the time in the ulcer in the sole of the foot, the location will be either on the heel or on the metatarsal heads or on the big toe. See, when we stand, the weight of our foot, like let's imagine if this is foot, when you're standing, the weight of your body will mainly fall either on your heel or will fall on metatarsal heads or on the big toe per se. So if they give you an image-based question where there's an ulcer present on the areas that I've just mentioned, then it would be a neuropathic ulcer related to diabetes. And why do ulcers do not heal in diabetes? That's because of angiopathy, because of a development of arteriosclerosis. Earlier I was talking about atherosclerosis. You know the difference from pathology, right? Atherosclerosis is involvement of tunica intima, where there is a atherosclerotic plaque and there is fat deposition. But arteriosclerosis is increase in the thickening of tunica media, because of which the blood vessels will become relatively narrow, and therefore you will notice even clean surgical wounds take a long time to heal. I mean, why do surgeons make a big face every time they have to operate on a diabetic? Is because even if they do surgery properly, that incision site, no, it's a clean surgical incision. That incision site, the scar formation takes a relatively longer duration, And even if the scar tensile strength is considered, as compared to normal person, the scar would be relatively weaker. So we always have delayed wound repair in diabetics. I mean, from the neuropathic ulcer component, what you've learned is one, I mean, why are you having ulcer in the sole of the foot? I explained distal sensory loss. Plus, an additional fact which I think I've been able to explain to you and should be remembered by you is delayed wound healing is encountered in diabetic patients. This delayed wound healing is due to presence of angiopathy. And what I am in medicine saying as a angiopathy, from the pathology perspective, this angiopathy is going to be referred as arteriosclerosis. Arteriosclerosis means increase in the thickening of tunica media, and therefore the lumen of the blood vessel will become relatively narrow, and that explains why the healing process is always slow in diabetics. I mean, infected wound, understandable. Non-infected clean surgical wound taking a long time to heal, that's because of angiopathy also present in diabetics. Then comes the issue of diabetic nephropathy, which has been dealt in the kidney section as well, but we'll focus on some core MCQs. We will say histopathology perspective on a kidney biopsy. What will be the most common histopathological finding? Then the commonest histopathological finding in diabetic nephropathy is presence of diffuse glomerulosclerosis. But if he says what is the characteristic finding, then your answer would be Kimmelstein-Wilson change. They can give you slides of the same as well. So while you are studying these two terms, it is good idea to just quick have a look at these two datas from pathology as well. Nodular glomerulosclerosis is referred to as Kimmelstein-Wilson change. So there are actually three findings that we encounter: diffuse glomerulosclerosis, nodular glomerulosclerosis, and Armani-Epstein change. Armani-Epstein I've not written here because that is discussed in the kidney section. But yep, I mean, at least one should be knowing regarding that, okay, the kidneys would be affected to the level that person can go into CKD and might be requiring renal replacement therapy. Therefore, what is the screening test that you will be writing for your patient? The screening test would be answered by you as, the short form of that would be UACR, that is urine albumin creatinine ratio. The screening test is urinary. We'll take a spot sample of the urine. Here you don't need to go for a 24-hour urine sample. You can go for 24, but it's advisable, and most of the time patient when he comes, spot sample is easily available. So in the numerator, you will be taking care of the albumin component. And in the denominator, it is still the urine, and what you are checking in the denominator is urinary creatinine. And if you read a report in which the values given like this, 30 to 300 milligram of albumin per gram of urinary creatinine, it means the kidneys are damaged. When I tell a diabetic patient, sir, your kidneys are damaged with this report, he's laughing on me. He's saying, sir, are you kidding? I mean, I on Diwali season, there was a complimentary health camp organized by Lal Path Labs, one of the biggest labs in India, private labs in India. And they did a complimentary blood test on the Diwali festival because there was a camp in my society and my serum creatinine was normal. And you tell me that my kidney is damaged. I'll tell him, sir, that creatinine is very good test, but it will take a long time to rise, no? I mean, serum creatinine is very good test. It will rise when 50% or more of the kidney is damaged. So if you want to wait till 50% of your kidney is damaged and you want to know that your kidney is affected, fine, you can wait for it. Here I'm telling you, even when, let me say 5 to 10% of kidney is getting involved. So the patient got the concept. As I've said earlier, in type 1 diabetes mellitus, it will take approximately 5 years for a person to end up with development of either a nephropathy or a retinopathy. N stands for nephropathy, R stands for retinopathy. The nephropathy and retinopathy progress with the same speed. In type 2 diabetes mellitus, for development of a nephropathy / R retinopathy, it will take 15 to 20 years. If the kidneys are involved, scan the eyes. If the eyes are involved, scan the kidneys. And as far as the intervention is concerned, because this urinary albumin creatinine ratio is in the range that I have mentioned at the moment. And coming to the management of this patient, I'll be starting him on a low dose ACE inhibitor. Most patients, when I'm going to write him, let me say, Ramipril 2.5 milligram, the patient might actually ask me that, sir, this is an antihypertensive drug. I'm not hypertensive. He's only a diabetic. He says, I'm not hypertensive. Why are you writing this drug for me? So I'll tell him that this drug is basically used because it will slow the progression of damage in the kidney. So low dose ACE inhibitors would be given along with SGLT2 inhibitors as well. SGLT2 inhibitors are again going to improve not only the cardio but the renal profile of a patient. Though in the internet, SGLT2 inhibitor can be used even up to 20 ml per minute, but in the current edition of Harrison, he has given a range. I mean, for different drugs, he mentioned 30 to 45. So I'm just taking upper limit at this point of time. All the message here is once the person is going into CKD stage 3B, that is when you need to be a little cautious, and we need to stop metformin at this particular point of time, and we will also be starting insulin in the patient. And do remember that insulin per se. I mean metformin, because once the GFR is going on lower values, I'm stopping metformin. And even when I'll be giving insulin, because insulin is excreted by the kidney, so dose reduction of insulin will also be required. This was itself a All India PG, that is NEET, now called NEET PG MCQ, that in a person with diabetic nephropathy, I mean, how will insulin be given? Proportional to the amount of body weight, dose reduction, dose increment. The answer is a dose reduction, because as I explained, insulin is metabolized by the kidney, so the dose reduction needs to be done. So these are long-term complications in diabetes, and then we have skin manifestations as well. Acanthosis nigricans is well known to us, so he can ask you regarding skin manifestation that is seen on the shin and can have a central ulceration as well. He can give you an image-based question also. Then the skin manifestation in type 1 diabetes is necrobiosis lipidoica diabeticum. Another MCQ that has been asked in the exam from the skin manifestation perspective is a dermatological feature that is seen with glucagonoma. You would have listened, if you listen to the discussion of mine on YouTube, then I've done this MCQ even in the medicine section. Otherwise, even the dermatologist is talking about it. That is necrolytic migratory erythema. So instead of just talking about acanthosis nigricans, first I'm trying to bring to your attention the ones that the examiner would like to ask. Glucagonoma again has impaired glucose tolerance. Glucagonoma patients will again be having impaired fasting glucose, and it can go in the diabetic range as well. So these patients, the MAT manifestation is necrolytic migratory erythema, necrobiosis lipidoica diabeticum. By reading the word diabeticum, everybody can answer diabetes, but which variety of diabetes? Type 1. And acanthosis nigricans. I mean, standard bread and butter MCQ to end this longest discussion would be on the neck of the patient, in the axilla, it's a velvety varicose thickening of the skin. Acanthosis nigricans is a feature of insulin resistance, so it would be seen in patients of type 2 diabetes mellitus. It will also be encountered in PCOD because there is insulin resistance present. Then the third condition, and was a MCQ of the previous years, is metabolic syndrome. I mean, 1 and 2 are obviously simple and straightforward, so metabolic syndrome needs to be remembered. And for part number 4, I want to tell you that acanthosis nigricans can also be a manifestation of internal malignancy. That manifestation of internal malignancy means that if a person is having pancreatic cancer, I think you're aware, the Apple guy, Steve Jobs, right? He died because of pancreatic cancer, and he started having this hyperpigmentation of the skin also. So carcinoma pancreas, carcinoma stomach, carcinoma colon are cancers which can contribute to this dermatological manifestation. So acanthosis nigricans is anyway not to be taken casually, because it could be a manifestation of an internal malignancy which is occult at the moment. So we'll be doing a PET scan in the patient to pick up this occult malignancy. So yes, it's seen with insulin resistance, but then apart from the top 3 areas of insulin resistance, it can be a manifestation with cancer as well. So these are the details that I would like you to remember for this video. I know it took a while for you guys to finish this one, but I assure you this will be worth the effort, and you'll be able to get your questions right. And especially, I mean, take up the pharmacological aspects also very seriously. After listening to this video, I think not only the therapeutic and the management part, but even the drugs part would also become relatively more stronger. That's what we are doing, right? We are trying to become mentally more stronger on a daily basis. We are trying to amp up our knowledge base. We're trying to increase our mental power, mental strength. I mean, being a doctor, it's all about this hustle, right? I mean, if you come to the end of this video, if you finish this video at, let me say, 1 or 1.5x, not at 2x because my voice would be croaking, but you've done it at 1.5x, and I know it's been a long one, then I assure you the fact that you are doing the right thing for your career. I mean, this is what the hustle is all about, so that you can break on to the other side. So I finished this video by saying, guys, keep hammering, keep this pressure on, and I'm very sure with this hustle, the hard work that you're doing, you will be able to get a desired rank, a desired seat. You would be able to get the desired marks in the exam. Like if you are an FMG aspirant, I assure you that if you're doing this, at 1.5 and you've done this to the end, I assure you that you are doing the right thing for your career, and you can go for that coveted 200 plus marks. And if it's gonna be a standard exam, NEET PG kinds or any set exam, that anywhere has a lot of negative marking, no? So I mean, it's a double-edged sword for you guys who are gonna be sitting for this competitive exam where negative marking is there. So I mean, you have to go aggressive, but then negative marking should be practiced on regular basis. So for that, I mean, try to do multiple choice questions on the topic, learn to do MCQs daily, guys, and you'll do great in your careers.